activities, lot of physical activities lined up. But to begin with, we have started up with this competition, which is online. And I welcome all the GC members, and I welcome all the esteemed members, and also the candidates, those who would be presenting papers. All the best to the candidates. Thank you very much. Now I would request our President, Dr. Indrani Hemant Kumar, Madam, to please say a few words, ma'am. Dr. Indrani, ma'am.
Thank you, Vishal. Good evening, everybody. Good evening to all my colleagues, the patron, Dr. Tej Kaul, and all the judges who have joined for this competition, as well as the students who are here to present their papers. As usual, Rsacp, you know, is behind academics, and this is another academic program where we give opportunities to everyone who can participate and win prizes through Rsacp. And without any much ado, I would like to just wish every student, everyone who's participating in this competition, good luck to them. And we have very eminent people as judges. So wish you all good luck, and let us go ahead with this competition. Thank you very much, and all the best to all of you.
Thank you very much for your encouraging words, ma'am. Now I would like to call upon our patron, Dr. Tej Kaul, sir, to Dr. Tej Kaul, sir, please.
Good evening, everybody.
Good evening,
nice
sir.
to be here with you, all of you, on this great occasion of scientific paper and case report competition. It's a great idea floated by our worthy president and the secretary and all the other executive members of the governing council. It is a new idea, and I'm sure there has been a very great response, a positive response, which is going to be very fruitful for the academic excellence of the younger generation, as well as for the health of the Research Society of Anesthesiology. I wish the participants best luck and best wishes so that they achieve laurels and excellence in the profession. Best wishes to the organizers, and a great thank you to Dr. Indrani and Dr. Vishal. God bless you all. Long live Rsacp. Thank you.
Thank you very much, sir, for your encouraging words, sir. Now I would like to call upon President-elect Dr. Naveen Malhotra, sir, for his kind words, sir, for his encouraging for the words, sir. Please, sir. Dr. Naveen, sir.
Heartiest congratulations to Dr. Indrani and Dr. Vishal. I am really very, very happy and very proud. This Rsacp scientific paper competition has begun the new year on a very big note. There has been a tremendous response to this brilliant idea of Dr. Indrani Hemant Kumar, the president of our esteemed society, Research Society of Anesthesiology, Clinical Pharmacology. And it has been exceptionally well executed by very dear Dr. Vishal Singla, the Honorary Secretary of Rsacp. I know he has been working day and night to make this program successful. And because of the combined efforts of the entire governing council, led by the president and secretary, it has generated a huge response. I look forward to excellent presentations on the consecutive 4 days back to back, whether by the postgraduates or by the senior residents and consultants or the case report section. I'm very sure the deserving will win, and I'm really very happy to note that the president and the governing council has sanctioned, in addition to the medal and certificate, a very good cash prize also. So I convey my best wishes to Dr. Indrani Hemant Kumar, Dr. Vishal, and other governing council members of Rsacp, and wish good luck to all the participants in different categories. Long live Rsacp. Jai Hind. Thank you very much.
Thank you very much, sir, for your kind words. Now I would like to call upon Vice President Dr. Anju Garewal, ma'am. Please, ma'am.
Thank you so much, Dr. Vishal. It is indeed a great, a pleasure, and of course, I welcome all of you on this occasion. Congratulations to the entire organizing team, especially our dynamic president, Dr. Indrani, Dr. Vishal, who are executing this so well. It is indeed a teamwork, and I see we all seek the blessings of Dr. Tej Kaul and Dr. Naveen Malhotra to run this program. For the students, I would like to exhort you all to join in large numbers, present, learn from each other, and also join Rsacp and the Journal of Anesthesiology, Clinical Pharmacology for a better vision and more inputs in future. Thank you so much. All the best wishes to all of you.
Thank you very much, ma'am. Thank you very much for your encouraging words. Now I would like to, Dr. Disha, have you logged in? Dr. Disha?
Yes, sir. I've logged in. Good evening, sir.
Very good evening also. Now, Dr. Indrani, ma'am, with your kind permission, should we begin the program, ma'am? Dr. Tej Kaul, sir, with your kind permission, should we begin up the should we begin the program, sir?
Vishal, sorry, is muted. Well begun is half done. Please start.
Yeah,
Thank you very
please.
much.
Thank you.
Thank you very much, ma'am. Dr. Disha, please welcome and introduce all the judges, please.
A very good evening to everyone. Today's session will be judged by our Honorable President, Dr. Indrani H. Kumar, President-elect, Dr. Naveen Malhotra, Vice President, Dr. Anju Garewal, Patron, Dr. Tej Kaul, and our Honorable Secretary, Dr. Vishal Singla.
Okay, the judges for today's session would be Dr. Rakhi Goyal, Dr. Vijay Lakshmi, and Dr. Nishkash.
Vishal, will you please give the rules of the competition?
Sure, ma'am. Sure, ma'am. Hello. Today, in all, we will be having 12 candidates for today's session. The scoring sheet has been circulated amongst all the judges. So the scientific, today is the scientific paper session. All the 12 PG students will be presenting their scientific papers. They would be allowed to speak for 7 minutes, and then for the further 2 minutes, there will be discussion and questionnaire would be there. Candidates would be supposed to answer those questions. Thereafter, the scoring would be made on the scoring sheets by the judges, and then the scoring sheets will be shared with me, and then the results would be finalized. Half of the candidates are given the time slot of 6 to 7 p.m. and half of the candidates are given the time slot between 7 to 8 p.m. So we hope it would be over by approximately 8 p.m. The list of the candidates has been is with you, Disha, and you are please supposed to call. You are please requested to call upon the first candidate.
So the first candidate for today's presentation is Dr. Prathamesh Kumar. I please request Dr. Prathamesh Kumar to log in and start his screen sharing.
Dr. Prathamesh, you have been made the co-host, so you would be able to share your screen. Please on your presentation and share your screen. You would be able to share your screen.
Disha, will you be able to time each candidate?
Sure, ma'am.
So it's 7 minutes, right? So
Yes,
1
ma'am.
minute before, at 6 minutes, if you could tell them that, 1 minute left.
Yes, ma'am.
And 7 minutes, please interrupt and said the time is over.
Okay, ma'am.
Good evening, everyone. Am I audible?
Yes, you are audible, Dr. Prathamesh. Please go ahead.
Okay. Good evening, everyone. My topic of presentation is sonographic diaphragmatic parameters and association with winning outcomes in critically ill patients on invasive mechanical ventilation, which is a prospective observational cohort study. I am Dr. Prathamesh, third year resident, AIMS Bhopal. And for this scientific study, my guide is Dr. Sunena Tejpal, and co-guides are Dr. J.P. Sharma, Dr. Saurabh Sehgal, and Dr. Rajesh Pal. As we all know, the invasive mechanical ventilation via endotracheal intubation is used daily as a life-saving technique in intensive care units. Prolonged mechanical ventilation increases morbidity, mortality, and costs. So early weaning from mechanical ventilation is of utmost importance. We have planned this prospective observational study to study diaphragmatic parameters like diaphragmatic thickness, thickening fraction, and diaphragmatic excursion with the help of ultrasound. As ultrasound technique is non-invasive, simple, cheaper, and easily available, along with other demographic and clinical factors, and to find their association with winning outcome. The aims and objectives are: the aim is to study diaphragm parameters by ultrasonography in critically ill patients undergoing mechanical ventilation and find association with winning outcomes from invasive mechanical ventilation. The primary objectives are to study diaphragmatic thickness, thickening fraction, and excursion in critically ill patients who are undergoing mechanical ventilation, and these parameters are recorded at 2 time points, which is before intubation and at the first attempt of spontaneous breathing trial from the mechanical ventilation. And the second is to study type of weaning in terms of simple, difficult, and prolonged in critically ill patients on invasive mechanical ventilation. The secondary objectives are to study correlation of diaphragmatic parameters assessed by sonography with the winning outcome, to study correlation of diaphragmatic parameters which is assessed by sonography with the ventilator-free days and survival at 28 days of ICU admission, and to find the predictors of the winning outcomes in terms of demographic, clinical, sonographic, diaphragmatic, and lab parameters. The materials and methods.
Pratesh, can you please switch on your video, please?
Video, okay, sir.
Excellent.
Okay. The materials and methods are: the type of study is prospective observational cohort study. The study setting is, it is a single-centered study conducted at Academic Tertiary Care Hospital, AIMS Bhopal. The study participants are critically ill patients which are admitted in our medical ICU requiring invasive mechanical ventilation. The inclusion and exclusion criteria are: the inclusion criteria basically include the patients with critical illness and patients aged more than 18 years and less than 80 years. And the exclusion criteria are: patients less than 18 years and more than 80 years of age, patients which are ventilated for less than 48 hours, patients with pre-existing diaphragmatic injury, phrenic nerve palsy, and surgery of diaphragm, patients with any local pathology which is preventing the USG examination in the right subcostal area, patients with pre-existing myopathy, intubation done post CPR, and patients in whom weaning will not be attempted due to multi-organ dysfunction. The study variables are the demographic parameters like age, gender, weight, height, and BMI. Then diaphragmatic parameters as previously involved, which is thickness, thickening fraction, and excursion. The clinical data mainly includes the history, which is comorbidities and addictions, which are different for different patients. Then vitals, which is temperature, systolic and diastolic blood pressure, and heart rate. Neurological status, which is assessed by the Glasgow Coma Scale. The respiratory parameters, basically PaO2 by FiO2, which is PF ratio, then respiratory oxygenation index, which is ROX index, then rapid shallow breathing index, RSBI, ABG parameters, and ventilatory parameters. Along with it, lab parameters as well as the SOFA scoring system is also included. All these will be assessed by some outcome variables, which are number of spontaneous breathing trials, number of days which are needed for weaning, days on ventilator, ventilator-free days, ICU stay duration, hospital stay duration, successful weaning, whether it is successful or not, whether it is simple or difficult or prolonged, and reintubation, whether reintubation in that patient is needed or not. As we can see, it is a USG view of the diaphragm. We have a Sonocyte M machine, the bedside USG machine, by which in critically ill patients we do echo as well as the diaphragm as well as lung ultrasound. Here we can see this is this ultrasonography of the diaphragm taken in the right subcostal region using M mode, and here we can see the excursion waves. The heap we can see it is inspiratory excursion, and then the thickened, the flat surface we can see it's the expiratory. These all parameters are these all diaphragmatic parameters are measured in the right subcostal region against the ecostructure of the liver. In the upper segment we can see the IVC, then liver, and some crescent shaped hyperechoic structure is there, which is the diaphragm. This image is seen in the M mode. And for diaphragmatic thickness, we use B mode ultrasonography with the linear probe. Now the statistical analysis. I have just calculated I have just taken the 10 patients and calculated the outcome in this study. A total of 10 patients were studied, and Pearson correlation matrix has been applied. And the statistical analysis tells us the patients having GCS greater than 12, SOFA score less than 4, thickening fraction in the range of 44% to 100%, excursion greater than 11.9 millimeter had shown simple winning, whereas patients having GCS less than 11, SOFA score greater than 7, thickening fraction in the range of 60 to 82%, excursion around 11 to 15.7 millimeters had shown difficult and prolonged winning. Here the Pearson correlation matrix has been applied. Here we can see the GCS, thickening fraction, excursion, SOFA scoring system,
30
and rapid
seconds
shallow.
remaining.
Okay, rapid shallow breathing index. These parameters are correlated with the winning outcome, number of spontaneous breathing trial, and ventilator free days. Here we can see the patients having thickness of greater than 36% and diaphragm excursion greater than 12 millimeters. These patients are 6 out of 10 having simple winning. Remaining 4 patients, 3 patients having difficult winning, 1 has prolonged winning. In these patients, the remaining 4 patients who does not have simple winning, they have met the diaphragmatic
As you
criteria
have
for the simple
exceeded your
winning.
time limit,
Okay.
kindly conclude.
Okay, ma'am. As the remaining 4 patients, they have 3 patients having difficult winning, 1 patient is having prolonged winning. They have met the diaphragmatic parameters for the simple winning, though the GCS and the SOFA scores came significant in predicting the winning. The significant correlation between the GCS and number of spontaneous breathing trials, which is Pearson minus 0.863, and the winning outcome is Pearson minus 0.815. Also, significant correlation between the SOFA scores and the number of spontaneous breathing trial, and the winning outcome is seen. So we suggest that the GCS and SOFA score are more important winning predictors in critically ill patients, and the only limitation is there. The study is done in 10 patients, so further data collection is required to correlate the diaphragmatic parameters with the winning outcome, as well as to find the association of ROX index and the rapid shallow breathing index with the winning. These are the some references which are related to the this study. Thank you.
Thank you, Dr. Pratmesh. I now invite the judges to start the discussion.
Pratmesh, a nice presentation. I just wanted to know, why did you select just 10 patients? Did you have anything in mind for the sample size?
Not exactly, ma'am, because initially the sample size calculation were tricky, because one means I have to take all the parameters at 2 time intervals, which is first in before intubation, and second is at the initiation of first spontaneous breathing trial. So it is easy to calculate it is easy to get all the parameters at the first spontaneous breathing trial. Some patients are there who intubated prior.
Pratmesh, I'll interrupt you. If you're taking a random number 10 as a sample size, would you be able to conclude anything in your, you had a slide for conclusion. So are you able to conclude that this is helping in the weaning, or it's a conjecture?
Ma'am, actually my sample size is 50, but I till now I can only get these 10.
So that there are two different things. So you have calculated sample size, but so far you have done 10.
Yes, ma'am. Yes, ma'am. Yes.
Presenting your preliminary part of the study.
Yes, ma'am. Yes.
I just wanted to ask the same question since Dr. Rakhi has done a good presentation, Dr. Prathamesh.
Thank you, ma'am.
Regarding the total number of cases, how many you have done so far, out of which you have taken these 10? You have excluded,
Ma'am,
right, some of them?
yes, ma'am. Yes, ma'am. Yes, ma'am.
How many?
Actually, I have done 30 to 35 cases out of 50, which is my exact sample size. And out of it, I just wanted to know what is the relation between all these parameters and the
Yeah.
weaning. So I
Out
have
of 35, you have excluded about 25 and 10 you have calculated, right?
Yes, ma'am. Yes, ma'am.
Okay. So one of the exclusions you said phrenic nerve palsy. How did you do the exclusion?
Sir, ma'am, for the phrenic nerve palsy, I have to get the history from the bystanders of the patient, as there is any neck trauma or the RTA which is involving the cervical spine, or there is any paradoxical
Inclusive
breathing.
exclusion, how do you do? That's all. History and all is not conclusive, right? So, okay.
Okay.
I think that's it. Any other questions? Dr. Nishkash?
So, Dr. Prathamesh, so very well presented. So, my question to you is, so you have done about 30-40 cases and 10 you are presenting. So, do you think whatever study you have planned, depending on based on the results you have got, you are going to change your practice in future? So, in short, what is the clinical relevance to you as a clinician in this study?
Yes, sir. Actually, I have to take more cases because the primary objective is to relate the diaphragmatic parameters with the weaning. So I have to take more number of cases regarding that only, sir. I have to change the practice.
Okay. No, okay, chalo. And another question is, so who did this ultrasound? So we had one anesthetist doing every ultrasound in all patients. So we had multiple number of people who doing the ultrasound and recording the data you wanted to present.
No, sir. Only one anesthesiologist is there to do the ultrasonography to reduce the inter-observer changes.
Okay. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you, everyone. I now invite Dr. Mangala Gauri Ji Bhatt to start her screen sharing and project her presentation. Dr. Mangala.
Yes, ma'am. Yes, ma'am. Just a minute. I'm not able to make it full screen actually. Just a second.
On the bottom side, the slide show is there, right? You go to that icon and just press it.
Bring your cursor down.
Bring
Okay.
the cursor down. The
Just
slide
a
show.
button above this on the left side. Come on the left side. Left. No, not this much. Just on this 66% where it is written 66%.
हाँ sir.
Less.
उसके left में.
Left. This is right. Left.
Okay.
Left.
No.
More left.
Sir,
More
actually,
left,
it's
more
not
left.
visible in my screen actually.
Doesn't matter. You present like this only. Doesn't matter. Hardly matter.
Should I try once more, sir?
Sure.
Gauri,
On
just
the left
and
of this
otherwise
minus
you're
button.
losing of time.
It's
Just
okay.
press
Okay, ma'am. Okay, I'll start like this.
Yeah, please.
Good evening, everyone. My presentation is on comparative study of preoperative ultrasound guided assessment of gastric contents in adult patients with and without comorbidities under the guidance of Dr. Indrani Hemant Kumar, ma'am. I am JR3 resident in depth of anesthesiology, KM Hospital. So the perioperative aspiration of gastric contents is a serious complication under anesthesia, and it can result in severe pneumonia requiring mechanical ventilatory support. The severity of resulting respiratory compromise is thought to be related to both volume and nature of the aspirate, with particulate matter carrying the highest risk. Gastric content and volume assessment is a new point of care ultrasound usually that helps in anesthesiologists to determine the aspiration risk. Healthy fasted patients frequently have the residual gastric volumes of up to 1.5 ml per kg without any significant aspiration risk. So the aim and objective of our study was to determine the gastric volume and content in normal ASA1 patients and ASA2-3 patients, and to compare the gastric volume and contents. So the secondary objective is to correlate the gastric contents with respect to presence of comorbidities and duration of starvation. So our study was prospective comparative study. So our sample size was 140 patients undergoing elective surgeries. They were divided into two groups containing 70 patients. So the inclusion criteria was age varying from 18 to 70 years, patients of both the genders, patients undergoing all kind of elective surgeries with adequate starvation. Adequate starvation implies patients with minimum 6 hours or more than 6 hours of starvation, irrespective of liquid or solid, either under general anesthesia or regional anesthesia, and ASA classification 1, 2, and 3. Exclusion criteria: patients who are not willing to participate, and patients posted for emergency surgeries, pregnant women and children, and patients with gastric outlet obstruction and decompressing nasogastric tube in situ. So after obtaining clearance from ethics committee and written informed consent, patients were divided into two groups: group A containing ASA grade 1 and group B containing ASA 2 and 3 patients, mainly diabetic, hypertension, CKD, chronic liver disease, hypothyroidism, and obese patients. So the preoperative assessment was done with basic demographic details, detailed history, and routine investigations. A curved array low frequency probe was used in abdominal scan mode settings, and the epigastrium was scanned in sagittal plane, sweeping the transducer from left to right subcostal margins. So the scanning was done in first supine position, then later in right lateral decubitus position. Gastric antrum is usually found superficially between the left lobe of the liver, and posteriorly there is pancreas. Either we can use landmarks as a aorta or superior mesenteric artery or the inferior vena cava. Then we take a still image of the antrum between the peristaltic contraction. Usually the empty stomach looks like target or bullseye pattern. This is the liquid content. Usually they are hypoechoic or anechoic. With increasing volume, the antrum becomes round and distended with thin walls. So frosted glass pattern is usually seen when the patient is having solid content in the stomach. And when the air is displaced and solid content can be better appreciated, it usually looks like a starry sky appearance. So later we calculated the cross-sectional area using the anteroposterior diameter and craniocaudal diameter. Then this antral cross-sectional area was substituted in Perlas and colleagues formula for the calculation of gastric volume. The data was represented descriptively using mean and proportion. The ANOVA test and t-test were done for statistical significance, and p-value of less than 0.05 was considered statistically significant. So the basically demographic characters were comparable in both the groups, like age, gender, and BMI and other comorbidities. So the Turkish HSD test for multiple comparisons found that the mean value of gastric volume in patients with chronic kidney disease with diabetes mellitus and hypertension was significant when compared to all the patients. With respect to starvation, on comparison of the gastric volume in right lateral decubitus position with respect to duration of starvation, a Friedman ANOVA test revealed that there was statistically significant difference in mean gastric volume between at least two groups. Even the Turkish HSD test for multiple comparison found that there was a significant difference between 6 to 8 hour group and 9 to 11 hours group. However, one CKD patient with diabetes mellitus and hypertension, even with starvation of 12 hours, he had a semi-solid content. It is also observed that mean gastric volume decreases with increased starvation time. In group A, out of 70 patients, 68 patients had empty stomach, one patient had semi-solid content, and one patient had liquid content, whose starvation was varying from 6 to 8 hours. In group B, out of 70 patients, 66 patients had empty stomach, two patients had semi-solid content, one patient had solid content, and one patient had liquid content, with starvation period varying from 6 to 12 hours. CKD patients were found to have delayed gastric emptying, and gastric contents were found even at 12 hours of starvation because they have electrolyte imbalance, mucosal edema, direct toxicity of uremic retention molecules. Also, the hormones which are involved in the modulation of GI motility and regulation of hunger and satiety were significantly altered. Long-standing uncontrolled diabetes mellitus patients who are more prone to have delayed gastric emptying when compared to controlled diabetes of short duration because of autonomic neuropathy. As the BMI increases, mean gastric volume was increasing, but it was not statistically significant. Limitations being, starvation period was not uniform. It was varying from 6 to 14 hours, And group B included many comorbidities like hypertension, chronic liver disease, hypothyroidism, and ischemic heart disease, stroke, which did not show any significant change in the gastric contents. So the conclusion is gastric ultrasound is used by many anesthetists in preoperative period to confirm the gastric contents and volume. Our study demonstrated that regardless of fasting for longer than 6 to 10 hours, it will not ensure an empty stomach. Comorbid conditions like diabetes mellitus, obesity, and chronic kidney disease, patients tend to have delayed gastric emptying compared to normal patients. As the starvation has increased, the mean gastric volume was increasing. Thus, even patients with comorbidities, which usually prolongs gastric emptying, also might have normal volume as the starvation time increases. Thank you.
Thank you, Dr.
Gauri,
Mangla.
Gauri,
Yes, ma'am.
that's a very nice study. But I'm a
Thank you.
little tricked on your starvation period. If it's
Yes, ma'am.
not uniform, then how do you conclude? I mean,
That was one of the limitation.
where if
Yes.
we do not standardize starvation period, and everything depends on the
Yeah.
period. That's what you concluded.
Yes, ma'am.
That if the
That was
period is
one of
more,
the
even with
limitations.
delayed gastric emptying. Yeah.
Yes, ma'am. That
So,
was one of the
but
limitations.
how did you find doing? Did you do it yourself or
Yes, ma'am. Yes, I have
somebody
done.
else did?
No, ma'am. I have only done all the. So after initial training by my seniors, I started doing. So all the patients, I only performed the gastric ultrasound.
Very nice. You think it will help you in the future
Uh,
in taking a decision whether to give GA or not?
Yes, ma'am. Definitely. What I feel is when we are not very sure about starvation period and when we cannot really rely on patient history, when the obscure history or patients who are like psychiatry patient, when we cannot relay their whatever they are saying. And I think in those situations, definitely it's going to be one of the best tool to assess the
So,
gastric
Gauri,
volume.
if you make your study more robust in terms of study design,
Yes, ma'am.
you'll be able to conclude better so that,
Yes,
you know,
ma'am.
it's a really change of clinical practice kind of study,
Yes, ma'am.
you know.
Thank you. Yes, ma'am.
So, but you have to make it robust. And another suggestion is don't put everything on your slide because then you tend to read every word from your slide. I know
Okay,
you
ma'am.
know the stuff,
Yes.
but write less so that you speak more out of your head. Your head is better than your slide. Yeah.
Okay, ma'am.
So, Dr. Mangla, so
Yes,
how
sir.
did you calculate the sample size in this patient? So, because these studies usually require very large number of patients to be recruited before you can
Yes, sir.
meaningfully see the results. So, what was the basis
Sir,
of?
we had applied one formula.
Mhm.
The statistician, with parenthesis article, we had put one formula for sample size, which came out to be 140.
What was the primary objective in your study?
Sir, to compare the gastric volume and content in ASA1 patients, and we will correlate the gastric volume and content in ASA2 and 3 patients. Is there any difference in gastric volume and content? Because the comorbidities were varying, like lot of comorbidities were there, so I think it was a bit difficult to compare. If it was like only one comorbidities, like say only diabetes or CKD, I think it would be more easy for us to compare. But our study was basically ASA 2 and 3. So there are a lot of comorbidities. But our positive findings was only in diabetes mellitus and CKD patients.
So, what was your research hypothesis? So, when you had planned the study, you must have kind of made a broad hypothesis based on which you made this study. So, what was the research hypothesis for the study?
Sir, in one of the study by Columbia Asia Hospital, Bangalore, they had done a similar study. Even their sample size was around 100. They had also compared between ASA1 patients and ASA2 and 3 patients. They had got like more positive findings towards uncontrolled diabetes mellitus, CKD, and obesity patients, but the results were much more in their study when compared to our study. I have got more of empty gastric and antrum in most of my patients. Like out of 140, only 6 patients were found to have gastric contents, and all the remaining 134 patients have to be found to have empty gastrum.
probably the fasting times were too
Yes,
long
but
enough to.
that's a biggest disadvantage, because here the patients like the starvation like since more than 10 hours, 14 hours also. So that makes it difficult for us to assess. That was one of the limitation of the study. I think if we could make the starvation period like limitation like from 6 to 8 hours or minimum of 8 hours, more not more than 10 hours. If we limit our inclusion criteria to that, I think we can get a better result.
But that would be challenging, no, because across the setups, mostly, if especially
Yeah, that too in elective surgeries, it is difficult, sir.
so maybe emergency surgeries
Yes, sir.
would have.
Yeah, I think in emergency surgery, it would be better if we can compare.
Okay.
So I have one suggestion, Dr. Mangala, very well done. Your
Thank
study.
you, ma'am.
Two things, like as Dr. Nishkarsh has said, the timing of the fasting cannot be controlled. But what I would like to suggest is, since what you cannot control, you cannot change.
Yes,
What you have, probably you can do a subgroup analysis of so much number of hours of fasting, what was it, versus so many number of hours, what was the result. You can do a subgroup analysis in those groups of comorbidity. What
Okay.
you found at the end of 6 hours, 8 hours, 10 hours, and then analyze them.
Okay, okay. Yes,
This is
ma'am.
one
Exactly.
suggestion.
Yes,
And
ma'am.
I just wanted to find out whether out of this study you could come to a conclusion and recommend in these subgroups whether additional measures can be taken,
Yes, ma'am.
or
Yes,
you want
ma'am.
to delay your case. What?
I think if we find like especially in diabetics and CKD patients, we found lot of like increased gastric volume, and even their antral surface area was comparatively very much higher when compared to ASA1 patients. So definitely I would suggest all the anesthetists to use this tool, and so that we can be careful enough doing induction. Like we can plan our anesthesia accordingly, like rapid sequence induction, or we can be very careful so that because we know that there is a this much of content is present or this much volume is present in gastric antrum.
Thank you.
Thank you, ma'am.
Thank you. I now invite Dr. Kazi to share his screen. You can start, Dr.
Am I
Kazi.
audible?
Yes, you are
A very
audible.
warm good evening. A very warm good evening to worthy jury members, respected seniors, and my dear colleagues. I'm Dr. Kazi Afan, and I'm a third-year PG resident in the Department of Anesthesiology and Critical Care, Government Medical College, Srinagar. I'll be presenting a paper titled "Cross-Leg Sitting Position for Subarachnoid Block in Pregnant Patients Undergoing LSCS. Is it beneficial?" A prospective observational study. History of regional anesthesia. The development of regional anesthesia started with the isolation of local anesthetics, the first being cocaine, which was used by Auguste Baer in 1898 for first operation under spinal anesthesia. What are the factors that affect success of spinal anesthesia? The quality of landmark, skill of anesthesiologist, patient position, lumbar flexion, distance between the skin and subarachnoid space. What happens with improper patient positioning while attempting subarachnoid blockade? Repeated spinal needle insertions, increased risk of back pain, post-dural puncture headaches, epidural hematoma, and neural trauma. Traditional sitting position and lateral position are the two commonly used positions for attempting subarachnoid block. In traditional sitting position, the success rate of spinal needle placement on first try is 40 to 50%. The cross-leg sitting position is one of the alternative positions recommended for administration of regional anesthesia. The cross-leg sitting position causes hip and knee flexion, resulting in posterior pelvic leaning and reduces lumbar lordosis. The research question: why cross-leg sitting position? The aims and objectives in our study were to assess the successful needle placement for subarachnoid block in patients planned for LSCS in cross-leg and traditional sitting position, to evaluate changes of bone hitting and needle manipulation, to compare patient and operator ease. Materials and methods. This prospective observation study was conducted in Government Lal Ded Hospital, Srinagar, over the period of 2 months. A total of 200 study subjects who underwent LSCS were included in the study after obtaining informed consent. The study subjects were categorized into two groups. Group A, comprising of 100 patients who received spinal anesthesia in traditional setting position, and Group B, comprising of 100 patients who received spinal anesthesia in cross-leg setting position. The categorization of the patients was done by convenient sampling method and in the ratio of 1:1. The proportion of spinal needle placement to the subarachnoid space, ease of landmark palpation, and the number of needle bone contacts in both groups were then assessed and analyzed. Inclusion criteria: pregnant females 21 to 35 years of age, ASA physical status of 2 who plan to undergo LSCS under spinal anesthesia. Exclusion criteria: patients who refused the spinal anesthesia and subjects with relative and absolute contraindications to spinal anesthesia. Results and demographics. In our study, the demographic profile of the patients were statistically non-significant, and this provided us uniform platform to evenly study the both groups. The landmark palpation: 88% of the patients in cross-leg sitting position had easy landmark palpations as compared to 76% in traditional sitting position. Needle bone contact: 68% patients in cross-leg sitting position had zero needle bone contact as compared to 52% in traditional sitting position, as compared to 52% in traditional sitting position. The 21% of the patients in cross-leg sitting position had 1 to 3 needle bone contacts, while as 33% in traditional sitting position had 1 to 3 needle bone contacts. And 11% of the patients in cross-leg sitting position had 4 to 9 needle bone contacts, and 15% of the patients in traditional sitting position had 4 to 9 needle bone contacts. Success of needle placement in first attempt: 74%. It was observed in our study. It was observed that cross-leg sitting position was more appropriate than traditional sitting position, as 74% of the patients had successful needle placement on first try among cross-leg sitting position group than traditional sitting position, which was only 66%. The post-op complications were limited to low back pain and post-dural puncture headaches, with only 5% of the patients in cross-leg sitting position had low back pain, and post-dural puncture headache was noticed in 2% of the patients in cross-leg sitting position, as compared to the traditional sitting position, that was 8% and 5%. Level of comfort: it was reported that cross-leg sitting position technique was more comfortable for the study participants than traditional sitting, as 94% study participants among cross-leg sitting position were comfortable during procedure as compared to traditional sitting position, that was 78% only. Discussion: the cross-leg sitting position was more appropriate than traditional sitting position, as majority of the patients among cross-leg position had successful placement of needle in the first attempt. There was very less needle bone contact than traditional sitting position. Accuracy of palpation of landmark was high, and level of comfort was high among the patients in cross-leg sitting position. The findings are consistent with the study conducted by Puthin-Vettel and et al. In 2020, wherein it was reported that cross-leg sitting position during administration of epidural catheter for labor analgesia was more effective technique than traditional sitting position, as there was more successful attempts, more comfort, and easy palpation of landmarks. Similarly, Mangala, SK et al. In 2016 also observed the cross-leg sitting position during administration of spinal anesthesia for surgical procedures was more appropriate technique to promote patient's comfort and has more rate of successful spinal needle administration in first attempts. Conclusion: our study concluded that cross-leg sitting position is more appropriate than traditional sitting position, as majority of the patients were more comfortable in cross-leg sitting position than traditional sitting position, with better landmark palpation. Further, majority of the patient had successful needle placement in first attempt with less needle bone contact in cross-leg sitting position. Thank you.
Thank you, Dr. Kazi. I now invite the judges for discussion.
Dr. Ghazi, you have presented very well. I have two basic questions. So, firstly, you mentioned
Thank you, sir.
you had used a convenient sampling for randomly dividing the patients into two groups. So, what is a convenient sampling method? Can you just elaborate?
Yes, sir. Sir, convenience sampling method. We did the study according to our convenience. Like we did not do any randomization of the patient. We just did the study by our convenience, sir. As the patient came, we did it in the ratio of 1:1.
So,
In one patient, we made to sit them in cross-leg position and one patient in traditional sitting positions.
so the initial choice was kind of based on the person who was doing the spinals. So he decided.
Sorry, sir.
So depending on the person who was there on the duty, so he decided the patient group allocation. So there was no.
Yes, sir.
Okay. Okay. So then there could be a bias that if you find it is easy, then you can do the traditional way. And if you have,
Sir, but we did it. Yes, sir. So we did it in the ratio of 1:1. Like one patient, we, irrespective of their ASA status or irrespective of their weight or the physical attire of the patient, we did it in the ratio of 1:1. One patient we made to sit in cross-leg sitting position, and the next patient next to him, which was planned, it was done in the traditional sitting position, sir.
so their BMI and weight were comparable in the both groups.
No, sir. It had no demographic. It had no significant this statistical significance in our study, sir.
Okay. And another thing is that in both the study groups you had multiple needle bone contacts. So we have now good methods
Yes, sir.
considering the pregnant patients are little difficult to put in spinal because of their obesity, because of the weight and the active labor they might be in. So why not use an ultrasound to spot the right place and with the spinal? So what additional advantage we get by using cross leg position as compared to the normal position?
Sir, in normal position, as our study says that it provides comfort to the patient. Like in traditional sitting position, there are hamstrings are stretched, and with the abdomen distended, patient is not that comfortable. As in this part of the world, the Kashmir, basically we are used to sit cross leg basically, so it gives them a feel at home as well.
But I feel it may be tricky for the patient to sit cross leg on the OT table, which may not be wide enough to allow a cross leg position of the patient who is pregnant. It is different. No, sitting on a bed or a floor on cross leg is much easier.
So it is difficult for both in both the cases, but cross leg, we found in our study that cross legs was much comfortable than the traditional sitting position, sir.
Okay.
So I have one
Thank you.
question, Dr. Raki. Shall I go ahead?
Yeah, please go.
So your study had both included elective and emergencies? Or only,
Sorry?
or both electives and emergencies, or only elective cases, your study?
No, only elective
What do you
cases,
think, would this position be useful in emergencies? LSE is most often on our duty days, we end up with emergency LSEs. What do you think?
in lateral positions.
Why, I mean, probably, how did you conclude that way?
No, basically, ma'am, can you please repeat the question?
So what I'm saying is this position you said, it would be useful in emergencies. Would it be useful in emergencies? What do you think?
Yes, ma'am, it will be useful in emergencies, ma'am.
So for that conclusion,
Definitely, ma'am, as the patient will
be... Your study says only elective, right? Are you planning to
yes,
do
ma'am,
another study?
Yes, ma'am, we might, ma'am.
Okay. And because patient discomfort may be different in such circumstances. So
yes, ma'am.
Probably an elective. And one more conclusion you said was this is only in LSCS. Do you think this would be feasible in all other cases, any other cases? where you
Yes, ma'am. We have there are other studies like there are studies done in urological procedures. There have been they have been doing the cross leg setting, but they have been using cross leg setting position, and also during epidural procedures.
Okay, probably limitations would be some of the orthopedical where you cannot give this position.
Yes,
and
ma'am.
As Dr. Nishkash has said, the table as such may not be, sufficient, especially in an obese pregnant patient. Yeah. Well presented. Thank you.
So, Dr. Kazi, I'm a little intrigued here between legs hanging, cross-legged, lateral, elective versus emergency, cesarean versus non-pregnant, So the whole Pandora box has opened up during this discussion. So I think it's given you enough input to start another study. And maybe you can put all
Surely,
these
ma'am.
things. That's why we discuss,
Yes, ma'am.
That's why you have presented. So we can put it as limitation. You've done
Okay,
a
fine,
study,
ma'am.
put all these things as limitation to your study,
ma'am.
including.
Sir wanted to add something. Dr. Rathi.
Sure, sir, please.
Sir, please. Tej sir.
Tej sir,
He raised his hand.
sir, please, sir.
You need to unmute yourself, sir. You are muted, sir. Please unmute yourself, sir.
Hello.
Am
Yes,
I
sir, please.
audible?
Yes,
Yes,
sir.
sir.
Yes, sir. Very much, sir.
The cross leg, to obtain a cross leg position in a pregnant patient is not that easy. Probably, Dr. Kazi, people in your part of the country are more tuned to sit cross-legged in your day-to-day life. It
Yes,
may
sir.
be easy. Otherwise, the situation of the hip joint is such that cross-leg position to obtain it is just not possible in a pregnant patient at our place to have a cross-leg position, a real cross-leg position. That is my one question. Another point, so I feel that cross-leg position, to obtain cross-leg position itself is a very, very difficult in a, forget about an obese pregnant patient, a normal, average-sized, average BMI patient with pregnant to have a cross-leg position. In urological procedures, it is easy. Not in obstetric patient. You cannot have an ideal cross-leg position because all the times the hip will be flexed and touching towards the abdomen, which would be as good as the sting portion, otherwise normal what you do. Second is 200 cases elective surgeries. You said 200 cases elective surgeries in 2 months.
Yes, sir.
Was it like that? 200
Yes, sir.
cases
It is basically in
in 2
government
months?
Laldet hospital. It has a very huge turnover of the patients.
I know there are at least 300 cases are done every month.
Yes,
but
sir.
is it elective cases are 200? Because
Yes, sir.
75, more than 80% cases are emergency procedures.
So
Cesarean.
basically,
Elective
due to the
procedures,
huge turnover of, so basically due to the huge turnover of the patients, we do these procedures in emergency theater as well, not
is
only
what
in the
I am
routine. So yes, sir.
normal turnout of cesareans in Laldet hospital is round about 10 per day. Am I right? 300 cases per month. Am I right?
More than that, sir. We do
How many?
more than
Out of
30,
that,
40 patients.
if out of 300, you take 75, 80% emergencies, only 20-25% are elective. However, it is left you. I agree, whatever you are telling may be right. But about cross-leg, it may be easier for people living in Kashmir because they are well known to
Used to, sir.
maintain this
Yes, sir.
posture in their day-to-day life. Otherwise, it becomes difficult in our part of the country. Thank you. Otherwise, good presentation and a good idea,
Okay, sir.
but needs extensive
Thank you very much, sir. Thank you,
work
sir.
for future.
Thank you, sir. Thank you very much, sir.
Thank you so much. I now invite Dr. Akshata Tripathi to present her presentation and share her screen. Is Dr. Rakshita present? I now invite Dr. Atul Valathi to present.
A very good evening to everyone. Today I'll be presenting my paper on comparative clinical study.
Dr. Akshita, please put it on the screen mode, full screen mode. Yeah. Please go ahead. Please on your video.
Yeah.
On your video, Dr. Akshita.
A very good evening to everyone. Today I'll be presenting a topic on comparative clinical study of two different bolus doses of norepinephrine to prevent spinal induced hypertension during cesarean delivery. It was conducted by me, Dr. Akshay Pate. My guide was Dr. Mukesh Somvanshi. I'm a resident, PG third year resident of Government Medical College, Kota, Rajasthan. So spinal anesthesia-induced hypertension occurs frequently during cesarean delivery, and it is primarily caused by sympathetic blockade. So I'm not able to. Okay. A spinal anesthesia-induced hypertension occurs frequently during cesarean section and is primarily caused by sympathetic nerve blockade. Intraoperative hypertension is usually defined as mean arterial pressure less than 25% of patient's baseline value, although recent recommendations advocate maintaining maternal blood pressure closer to 100% of baseline to avert and minimize associated complications such as nausea, vomiting, decreased consciousness in mother, and uteroplacental insufficiency, acidosis, and impaired oxygenation in fetus. Hypertension caused by a reduction in systemic vascular resistance is physiologically compensated by increasing cardiac output. There were major strategies utilized. So I'm not able to see some slides. There were major strategies utilized to prevent spinal hypertension, include intravascular volume expansion with fluid preload using different vasopressors and lateral positioning of the uterus and mechanical compression devices. But in spite of all these maneuvers, spinal hypertension is still inevitable. Vasopressors like mephentermine, ephedrine, phenylephrine, infusion of angiotensin II, atrial natriuretic peptide, and norepinephrine are therefore commonly recommended to reduce the incidence of hypertension. Norepinephrine has been hailed as a good alternative because of its potent alpha-adrenergic agonistic activity and intrinsic beta-adrenergic potential, which theoretically results in a lower incidence of maternal bradycardia. Norepinephrine has been used both as an intravenous bolus as well as continuous infusion for prevention and treatment of post-spinal hypertension. However, intermittent intravenous bolus may be simpler, feasible, more acceptable method for routine practice in the low resource setup where either infusion pumps are not available or with limited availability. Aims and objectives. The purpose and aim of the present study was to compare two different bolus doses of norepinephrine given prophylactically for the prevention of spinal-induced hypertension during cesarean delivery with respect to the effectiveness of norepinephrine to prevent maternal hypertension, to determine optimal dose of norepinephrine, and to determine total number of boluses of norepinephrine required, changes in the maternal heart rate, neonatal outcome, and side effects. The study was conducted on 80 patients who were recruited in this prospective randomized double-blind study after fulfilling the inclusion and exclusion criteria, undergoing elective cesarean section under spinal anesthesia, who were assigned into two groups of 40 patients each. Group N6 received norepinephrine 6 microgram as an intravenous bolus dose, and group N5 received norepinephrine 5 microgram as an intravenous bolus dose simultaneously with subarachnoid block. The incidence of hypertension, requirement of rescue bolus doses of norepinephrine, hemodynamic parameters, adverse effects, and neonatal complications were compared and analyzed. All statistical programs were using SPS 21 version statistical program for Microsoft Windows. Inclusion criteria. Age 18 to 35 years, patients with ASA grade 1 and 2, full-term singleton pregnant patients scheduled for elective as well as emergence lower segment cesarean section. Exclusion criteria were patients' refusal for the procedure, ASA grade 3 and 4, infection at the site of injection, patients with PIH, chronic hypertension, cerebrovascular disease, bronchial asthma, coagulopathy or receiving anticoagulants, congenital abnormalities of lower spine and meninges, active diseases of the CNS, history of allergy to local anesthetics and study drugs, hypothyroidism, blood pressure more than 140/90 mmHg, preeclampsia. Statistically significant differences was observed between both the groups. It was found that after subarachnoid block, systolic blood pressure, diastolic blood pressure, and mean blood pressure were significantly lower in group N5, except at 4-minute and 5-minute, and continued to be low in the post-operative period, even after prophylactic bolus dose administered at the time of subarachnoid block. Norepinephrine 6 microgram was found to be more effective in preventing spinal-induced hypertension in terms of total rescue bolus dose requirements, which was significantly higher in group N5, 8.79 plus minus 7.39 microgram in comparison with group N6, which was 4.35 plus minus 5.08 microgram. There was no incidence of bradycardia in both the groups. There was in group N6, there was lesser incidence of hypertension in comparison to group N5, which was greater incidence of hypertension even after giving prophylactic bolus doses of 5 microgram as well as 6 microgram. Same is the case in systolic BP as well as the diastolic BP. There was a high incidence of hypertension in group N5. The rescue bolus dose requirement was higher in group N5 patients. Discussion: the results of Pleasant study showed significant change in the incidence of spinal-induced hypertension after co-administration of 6 and 5 microgram doses of intravenous norepinephrine with spinal anesthesia. However, there is a significant decrease in the rescue dose requirement of vasopressor in group N6 and also delay in the time to first rescue dose in group N6. Similarly, it was the same study was conducted by, somewhat similar study was conducted by Chaudhary Savita et al. Found
30
that
seconds remaining.
Incidence of post-spinal hypertension was 63.33% in group N6, 80% in group N4. Therefore, the intravenous bolus dose of 6 microgram norepinephrine when co-administered with spinal anesthesia was found to be more effective than 4 microgram. They actually compared 6 microgram as well as the 4 microgram. There was no significant difference in terms of the demographic data in a present study, similarly seen with Nagin P. W.T. et al., Chaudhary et al., and who also found no statistical significant differences regards demographic.
Your time is over. You kindly requested to conclude.
We conclude that to prevent spinal-induced hypertension, the intravenous bolus dose of 6 microgram norepinephrine when co-administered with spinal anesthesia was found to be more effective than 5 microgram norepinephrine. Thank you, ma'am. Thank you, teachers.
Thank you, Dr. Akshita. I now invite the judges for discussion.
Akshita, your study was interesting. Norepinephrine being a core drug, we still, used by a few people only, but yes, there's a lot of literature supporting it, and comparing 2 doses was good. But what was distracting? Please take my comment very, very, with a pinch of salt, because the whole idea is we need you to become better. We want you to become better. You can't write paragraphs in a PPT.
Okay.
You just shouldn't write paragraphs and then read them. No. So you have to write points and then speak.
Okay.
Yeah. Whenever you're presenting, you'll be presenting on bigger forums and you would like to win a contest. So it's very important that how you present is important.
Sure.
Okay. So point wise and all, you can take some guidance from people and make it better, the presentation part. And so sample size, how did you calculate?
Ma'am, it was according to the formula. It was according to randomized control trial using the formula.
No. So what do you mean by formula? You had some pilot study. How do you calculate when you compare 2 groups in a randomized control trial? What is the basis of your sample size calculation? Because you're trying to conclude something significantly, right?
Yes, ma'am.
So sample size is important?
Yeah, ma'am.
So how do you base it? Formula will be used when you give some inputs.
Ma'am, it was like we just selected few patients, out of 80 patients, we have divided those patients into 40.
No. That's a different thing. You have to understand the difference between sample size calculation means how many patients you need to study to come to this conclusion of, which dose is better, 6 or 5, right? So should I do 10 patients and conclude that, okay, 6 is better? Should I do 1,000 patients and conclude 6 is better?
Yeah.
You get me? So
Yeah.
this needs to be cleared in your mind, your approach.
Okay.
It's not about the formula.
Okay.
It has to be based. You have to see what you're trying to. You have any idea? No.
Ma'am, we have just randomly selected 80 patients and divided into 2 groups, and based on that only I performed the studies, ma'am.
Okay, so you need to go into depth of this. We can't discuss in totality, but you need to look into it. Yeah, otherwise very well presented.
Okay, well presented. So I have a couple of questions. What was this co-administration?
Ma'am, like while I was putting, while the spinal anesthesia was, spinal block was given, at that time period only the study drug was given, ma'am. At the same time, like after the drug is instilled, then at that time only the study drug was also given intravenously, ma'am, bolus dose.
And also later on?
Later on, ma'am, according to the requirement, it was given, ma'am. Like once the spinal hypertension is seen, according to that only, ma'am, rescue bolus doses are given, ma'am.
That is how much percentage of the baseline?
Ma'am, if the at the baseline less than 25% if it is falling, ma'am, we used to give.
Okay. Any other measures were done to prevent the hypertension in your cases?
Ma'am, actually, yeah, I just give the left side uterine displacement by putting a wedge under the right hip, ma'am, and basically in cesarean patients, ma'am, and also, ma'am, I tried to preload the patients like with the 10 to 15 ml of crystalloid, 10 to 15 ml per kg of crystalloid, ma'am, solution. Used to preload the patient. And
okay. So have you even studied, have you studied the neonatal outcome in your cases?
Yes, ma'am.
Measure?
Yes, ma'am. We assessed the FCAR score, but ma'am, there was no statistical significant differences in the even both the groups.
In your slide, I don't remember that.
Ma'am, I just put it in the discussion and that the time was over, therefore I couldn't mention it, ma'am.
Okay. What do you mean by double-blind study?
Ma'am, double-blind study in which the researcher as well as the participant, they're not knowing about the the procedure and everything, ma'am, about the about the treatment or whatever intervention we are going to do now, that the researcher as well as the participant is not knowing about the procedure, about the thing.
Okay, so the person who had administered the drug, the 6 mics or 5 mics, doesn't know whether it is 6 or 5, or it's a different person who was giving the drug.
Well, it was a different person who was giving the drug. Even the presenter was not giving the drug, and the other person was giving the drug, and the the patient or the whom we are going to perform the study, ma'am, the researcher, the participant is also was not. He was also that the person was also not knowing about the intervention what we're going to do, ma'am.
Thank you.
Thank you. Akshita, you had presented very well. So my question is that you had made 2 groups and you have given 5 mics and 6 mics, and you said it's blinded. So how did you ensure that the volume of 5 mic adrenaline was same as 6 mic noradrenaline? Otherwise, it would be difficult to blind. It has to be same color, same type of drug, same volume that you administer.
I said I didn't get you, sir. Could you please?
So you gave 5 mics noradrenaline in one group and 6 in the other group.
Yeah, sir.
What was the dilution? How did you make?
Sir, actually, which the noradrenaline which was used for the study, it was 0.2%. That is 2 mg per ml, ma'am, sir. And then, sir, I double diluted it. Like it was 1 ml as 2 mg. Then I diluted it in 10 ml. Then I've again diluted it. Then I've diluted, like if I'm making 6 microgram, then I have to, like 5 microgram, I have to dilute it. After double dilution, sir, I diluted it by till 5 ml, sir, until 4 ml, sir. That's how I received 5 micrograms, sir. And the same, like if
I could not get it. So you made 2 milligram per ml.
Yeah, I've double diluted it.
No, you dilute in 10 ml, so it becomes 2 milligram in 10 ml.
Yeah.
Okay. And then you took 1 ml of this?
Yeah, I took 1 ml of it. It was 200 mics, sir. Then, sir, I diluted
200 mics in another 10 ml. So it becomes 20 microgram per ml.
Yeah, after then I double diluted, that becomes 20 microgram in per ml. Then after that I have diluted it till like 4 ml, sir. Then it became 5 micrograms, sir. That's how I've made, sir.
So you made this 20 into 4.
Yeah, sir.
And what about 6?
The 6 likewise only, sir. I made 200 like 2000 like 2 mg in 20 ml, and then it is 100 microgram. Then so I have diluted it in just 10 ml, then double diluted. That's how I received 1 microgram, and then I have to give it 6 ml, like the 6 ml I have given, sir.
So that's what I'm trying to say. So you give 5 ml in one group and you give 6 ml in the other group.
Yeah.
So the person who is giving the drug knows which drug he is giving. So how do
Sir,
you
I mean, I've not mentioned it like it was 6 microgram.
मेंशन की जरूरत नहीं ना, वॉल्यूम फर्क है ना, वही तो मैं पूछना चाह रहा हूँ आपसे। वॉल्यूम फर्क है ना, एक में आप 5 ml दे रहे हो, एक में आप 6 ml दे रहे हो, तो उसमें बताने की क्या जरूरत है? देयर इज नो नीड एक्चुअली, द पर्सन हु इज गिविंग नोज व्हाट ही इज गिविंग।
No, sir, in one group I'm using 1 ml only, so it has like
So whatever, so the volume is
volume,
different,
yeah,
no?
sure,
Volume
sir.
is different, na? That is what
Yeah.
I want to ask. So can we do something to make the same volume?
So I actually this was the only way this was made.
No, you could have whatever amount of drug you want to give, you can dilute in total 10 ml, make it 10 ml, doesn't make a difference, no? It is the concentration you give, no? Dilution doesn't make a difference. Does it make a difference?
No, sir.
So that could have easily been done to ensure that right amount of blinding is being done for the, even if somebody is cross-checking, because cesarean OTs are mostly, they are panicky situations, everybody is everywhere, you cannot actually mask everything possible.
Yes.
So you have to do it in a way that it is not easy to identify which drug is being given. Secondly, you said you had given 1 to 1.5 liter of saline, or you use saline or ringer lactate?
Sir, RL only.
RL used. So, what do you think? Is it the right practice nowadays to give 1.5 liters?
No, sir. Actually, we used to like co-load only, so we don't do.
Especially if you're giving a prophylactic noradrenaline along with it. So this is given at the time of spinal, no, noradrenaline.
Yeah, sir.
So you are in any case giving a vasopressor to prevent a fall in blood pressure, and you end up giving 1 liter to a pregnant patient who has a heart. We know a lot of these physiological changes
Yeah,
are there. You might have ended up in a failure. So what actually you did?
So actually, we co-loaded it. We don't preload it, sir. Just the co-loading has been done. Once the patient comes in the OT, that's how.
So what was the end point? No, how much volume, or what was a hemodynamic parameter you were monitoring that you knew
Yes,
that
sir.
that was enough fluid for that patient when you were giving along with noradrenaline?
So
You got my question now?
yes, I got it, sir. So so actually we used to we gave Norad also. Along with that, we used to give the fluid also, and we assess the volume also according to that.
Okay, ठीक है. Thank you.
Thanks.
Can I ask a question up here? Sorry. Can I ask the question?
Please go ahead, ma'am. Please go ahead.
Yeah. To the candidate, why do you think vasopressors are needed in a pregnant patient to treat? What is the reason that you are using vasopressors in pregnant?
Ma'am, because of the progesterone and estrogen, there's a physiological changes in pregnancies, ma'am. Already there is a high incidence there's a decrease in systemic vascular resistance, ma'am, in pregnant patients because of the progesterone and estrogens, ma'am. Therefore, there's already a high incidence of hypertension seen.
We're not talking about incidence, no? There's so many other ways to do. Why are vasopressors preferred over fluids, and why they're so important to treat hypertension? What is that you're trying to treat?
Ma'am, so as to maintain the vascular tone, ma'am, so as to maintain the vascular tone of the blood vessels and all.
I would, suggest that the very valid points raised by all our esteemed judges, and that you should go back and look at what is the rationale of doing the study. Why am I doing this study? How did I choose the particular dosage, right? How did you randomize and how did you blind? Because randomization and blinding are two different things. And why do we pick a certain sample size? If we do not have proper answers to that, our research is of no use, So Thank you so much.
Thank you.
Thank you. Now I would invite Dr. Atul Valati.
Good evening, all. Am I audible?
Yes, you're audible.
Good evening, all. Myself, Dr. Atul. I am from IMS Jodhpur. My study I have done under guidance of Dr. Swati Chaprama. The study's title is Perioperative Course of Patients with Pre-Existing Neurological Disorders Undergoing Anesthesia for Non-Neurological Surgery, a prospective observational study. So a brief introduction. Patients with diseases affecting the central nervous system may need to undergo surgery unrelated to neurological disorders. So some of the common neurological disorders seen in the perioperative period are stroke, epilepsy, and Parkinson's disease.
You are not audible.
Some network issue or something, Dr. Disha?
Dr. Atul, are you there?
His video is also stuck.
Let me call Dr. Atul if he to check if there is any connection problem. He's not picking up. Can we have the next participant?
Yeah, I think Dr. Rakesh,
Yeah,
shall we
please,
go ahead with the next?
please call the next participant.
I would now like to invite Dr. Sridhar. Okay, he's back. I think.
Dr. Atul, are you there?
I think Atul is there now. You need to unmute Atul. Yeah, I think he's good. Looks like.
Sorry for the interruption. Hello.
Please go ahead.
Coming to the methodology, preoperative history of these patients were noted in the proforma in the PSC clinic. Comorbidities like hypertension, diabetes were noted. So any significant intraoperative event like greater than 20% increase or decrease in the hemodynamic parameters, aggravation of the underlying neurological disorder, or any other significant events like arrhythmia, etc. was noted. Postoperatively, patients were followed physically till discharge till 30th postoperative day telephonically. So inclusion criteria, it includes all adult patients aged greater than 18 years with ASA physical status 1 to 4 with pre-existing neurological diseases scheduled to undergo elective or emergency non-neurological surgery was included in the study. Exclusion criterion, patients who do not consent to participate were excluded from the study. Statistical analysis, data collected were tabulated in MS Excel spreadsheet. Categorical data was presented in numbers or ratio. Then coming to the results, there were total number of 55 patients. 2 patients had stroke along with Parkinson's disease, and other 2 patients had stroke along with epilepsy. So there was total pre-existing neurological diseases was 59. Out of that, there were 43 stroke patients, 10 patients with epilepsy, and 6 patients with Parkinson's disease. All patients were observed intraoperatively and postoperatively. Among stroke patients, 3 patients expired in the postoperative period, and among Parkinson's disease, only one patient expired in the postoperative period. Coming to the result, the mean age among the overall mean age was 57.6, and among stroke patients, it was 61.4. Among 43 stroke patients, 33 were female. There was a female predominance. Then among 43 stroke patients, 60% patients were hypertensive. And among stroke patients, 14% had history of coronary artery disease. Then among Parkinson's disease patients, 66.7% patients were posted for trauma surgeries. Most of the patients had history of fall. Most of the, among 80% of the patients were posted for under GA. and remaining patients were posted under regional anesthesia. Then among the 43 patients with history of stroke, 34.9% had history of residual paralysis and 62% were on dual antiplatelet. Then coming to the intraoperative events among stroke patients. Among the 43 stroke patients, 55.8% had an hemodynamically uneventful intraoperative course. 34.9% of patients had intraoperative hypotension, while 9.3% had hypertensive episodes. Then coming to postoperative events, 79% patient postoperative events were uneventful. Then 9.3% patient had hypotension, 2.3% had refractory VT, 9.3% had delirium, and 6.9% expired the postoperative period. Among the expired patient, 2 patients expired due to refractory hypotension and 1 patient expired due to refractory VT. Then distribution of events among the patients with a history of stroke from discharge till postoperative day 30. 82.5% was uneventful. 5% patient had delirium, and there was a loss to follow-up of 10%, and 2.5% expired. And coming to the patient with epilepsy, there was total 10 patients with epilepsy, and except 2 patients remaining, all patients were taking anti-epileptic drugs. The intraoperative events, it was 80% patient, it was uneventful. 20% patients had hypotension. And coming to the postoperative events, 70% patients had an uneventful postoperative period. 10% patient had hypotension, 10% had tremor, and 10% patient had GTCS. Then coming to the events from discharge till postoperative day 30, 80% patients, there was an uneventful postoperative period, and 1 patient expired in the postoperative day 30. And coming to the patient with Parkinson's disease, all patients were taking Syndopa. 3 patients were taking Syndopa along with other medications. Coming to the intraoperative events of the patient with Parkinson's disease, 50% patients had an uneventful intraoperative period. Remaining 50% patients had hypotension and was on vasopressor infusion. Coming to the postoperative events, 66.7% there was an uneventful postoperative period. 1 patient expired in the postoperative period. Then one patient had delirium. Then events from discharge till postoperative day 30. 4 patients had no events. The postoperative period was uneventful, and 1 patient had delirium. And study limitations. The sample size was small because this was a time-limited study. To replicate our findings, similar studies with large enough sample size are required. So the outcomes of the study cannot be generalized because it was only conducted at 1 center. And these were some of the articles related to my study. Coming to the conclusion, the perioperative course of patients with pre-existing neurological disease receiving anesthesia for non-neurological procedures is unpredictable, which may be caused by brain injury itself or maybe due to related comorbidities. We found that there is much variation in the hemodynamics of the patient with pre-existing neurologic disease in the perioperative period when compared to other patients. Thank you.
Thank you, Dr. Atul. I now invite the judges to start the discussion.
Can I ask a question? So Dr. Atul, a good presentation, a good study. So from these conclusions, what do you make out, from the conclusions, how do you want to take forward? So what changes do you want to make in your practice from these conclusions?
Ma'am, actually 35% of the patient had intraoperative hypotension. So the hemodynamic parameters, we can't predict the hemodynamic parameters. So future studies can be done by comparing, say we can take stroke patients, then another group we can take patients with hypertension. So we don't know whether these hemodynamics parameters change is due to the pathological brain or due to the patients' comorbidities. Because the stroke patients, around 60% patients had hypertension. So we don't know whether it's due to the pathological brain or due to this.
So in your group itself, you have some without hypertension, some with hypertension, right?
Yes, ma'am.
You couldn't always do a subgroup analysis there, right? What I'm saying is, from your study, the conclusions are okay, crisp. I wanted to know what your study will make a difference in my practice. What I'll take from there.
Ma'am, actually, I read one article from Shankar et al. They used EEG guided anesthesia for cardiac surgeries by blocking the specific. The trial was known as Pathfinder trial. So we can use such EEG guided anesthesia for stroke patients. Once we confirm that the stroke patients have an intraoperative hemodynamic. Hello.
Yeah. Okay. What were the non-trauma surgeries that these patients underwent? You mentioned.
Ma'am, there were different types, ma'am. Around. Actually, I have classified that 3 patients had history of CA, then general surgery, inguinal hernia, hydrocele, pilonidal sinus. Then 1 patient was posted for TERP.
The complications more in these CEA cases or something like that? Have you observed such a?
Ma'am, 4 patients out of the expired 4 patients, ma'am. 1 patient was posted for emergency case. It was a perforation peritonitis. 1 patient, it was CVA with Parkinsonism. That patient was posted for IT fracture. That was a 90-year-old male. He was posted for IT fracture. So post-operative day 2, he had a refractory ventricular tachycardia and he expired. So most of the case, it was in GA only.
I think it was really nice that your guide prompted you to do this study, because it's a very laborious thing, and it's really laborious to collect so many data and a lot of conclusions. You can't really make a conclusion because, as you said, hemodynamic, it could be because of so many other reasons. You said delirium, it could again be because of so many reasons. So, but collecting this kind of data is a good initiative, I would say, and you did present very well. Even if from a research methodology point of view, it may not be perfect.
Dr. Rakhi, madam, you are muted, please. Dr. Rakhi, you are muted, madam, please. You're muted, ma'am.
Okay, maybe there's some network issue. So Atul, so one more question from you. Presented really well, and it is not easy to do such study, definitely. And this kind of data is not much explored as well. But the basic question from the design point of view is that the anesthetic technique used was not standardized in the patients. So you have different kind of drugs, different people giving anesthesia, some region, some GA.
Ma'am, मेरे ख्याल से you need to re-log in, ma'am.
So then it would end second. So that is the reason that you don't have common outcomes. So outcomes you have reported, but outcomes are not common. So we have different kind of patients, different kind of anesthetic technique used, and the outcomes are depending on the disease, not the common outcomes we are looking at. So in light of these limitations, how do you see your results?
Sir, actually, it's a limitation of my study, sir. I admit that. Actually, the anesthetic technique was, the discretion was given to the anesthesiologist, sir. Actually, it was a limitation.
So then we are bound to have different outcomes. No, we can have varied degree of hypertension. We can have varied degree of other problems which we are looking at. So how do we know it is because of the disease or it is because otherwise in the patient?
But sir, if we are giving GSR, we are already following a protocol, sir. So these drugs and all are common.
No, we have four induction agents, 4 or 5 opioids, 4 or 5 muscle relaxants. So I'm sure it depends on the person and the other comorbidities you may be using. It will be very difficult to standardize in such kind of study.
Yes.
Okay. So, Dr. Vijayalakshmi, any more questions or we can shift?
I think Dr. Rakhi has joined. You
Okay.
want to ask?
Yes, I logged in again. Were you able to hear me?
No, your audio was not good. Now you are
Okay,
able. Now
sorry,
you are able to.
sorry. So I just wanted to appreciate Dr. Atul and his guide that at least they made an initiative which is very good. You know, it may not be a perfect study at this point, but I think it's a good attempt. And there'll be a whole lot of factors which would make any conclusive statement very difficult. So, but it's a beginning and very well presented, your slides and, you know, timing, everything. Very nice.
Thank you. Thank you very much.
Like to appreciate the flow chart that he's presented. It is, it's very good. That's how you actually go ahead when you go for a publication. You need that. Good.
Thank you. Thank you.
Thank you, everyone. I now hand over to Dr. Neha to moderate the next session.
Thank you, Dr. Disha. Good evening, respected judges. I would now like to invite Dr. Sridhar for his presentation. Over to you, Dr. Sridhar, please.
Yes, ma'am. My screen share is there?
Yes, make it full screen.
Okay, sir. Yes.
It is there on the bottom. On the bottom.
Okay, okay. Yes, sir. It's
Doesn't matter, Dr. Sridhar, you move on with it. It's
okay,
visible. Please.
Shit. It's
Start your presentation, Dr. Sridhar.
Yes. Good evening all. Myself, Dr. Sridhar Nathuri Chopde. This is my topic, the comparison of erector spiny plane block and conventional analgesic technique for postoperative pain relief in cesarean section, a prospective randomized study. Under guidance of my guide, Dr. Suchita Joshi ma'am. In the introduction, the postoperative pain relief after cesarean delivery is challenging because it needs to provide maternal satisfaction while having no adverse effects on the baby. Spinal anesthesia is most commonly used anesthesia technique for cesarean delivery, as it provides rapid, effective anesthesia with no risk of failed intubation or aspiration of gastric contents. However, despite these benefits, spinal anesthesia does not provide adequate postoperative pain relief. There are many techniques, such as those involving spinal or systemic opioids, multimodal postoperative analgesia techniques. Ultrasound-guided bilateral erector spiny plane block is a new technique being used for analgesia after cesarean section. ESPB, that is erector spiny plane block, was initially described as a novel technique for neuropathic chest pain by Ferrero et al. At the T5 transfers process, and has extended its indications to the provision of analgesia in cervical region, abdominal cavity, and recently the lumbar region. The diversification of indications is partly distributed to its proposed mechanism of action. MRI, that is magnetic resonance imaging, shows that local anesthetic injected into the ESP spreads to the paravertebral and epidural spaces in both cranial as well as caudal directions from the point of injection. therefore potentially producing both somatic as well as visceral analgesia in multiple segments. The local anesthetic then blocks the dorsal and ventral rama of spinal nerves. By blocking both the dorsal and ventral branches of the thoracic and abdominal spinal nerves, it provides both somatic as well as visceral analgesia. So excellent pain relief occurs. ESPP gain wide attention as it is faster procedure and carries a lower risk of hypotension. Can be used in patients with coagulopathy, is easy to perform, and requires less training. Coming to aims and objectives, the aim of my study is to compare the analgesic efficacy of bilateral erector spinae plane block with that of conventional technique that includes systemic opioids and NSAIDs after elective cesarean delivery under spinal anesthesia. The primary objective was to compare effect of bilateral ESPB using 0.2% ropivacaine. It was 0.2 ml per kg. I have taken the drug on postoperative pain measured as visual analog scale VAS score within 24 hours in the patients under spinal anesthesia. The secondary objective to compare as analgesic consumption in 24 hours, postoperative nausea vomiting, hemodynamic stability, and side effects after bilateral erector spinae plane block using 0.2% ropivacaine, that is 0.2 ml per kg with conventional analgesic technique. The materials and methods we use. This is a prospective randomized double-blind comparative study. We have taken total 76 subjects randomly and divided into two groups. Group 1 is ESPB group who received bilateral erector spinae plane block using 0.2% ropivacaine before lumbar puncture for spinal anesthesia. And group 2 received conventional postoperative analgesia with IV tramadol 100 mg or IV diclofenac 75 mg or injection paracetamol 100 mg after shifting patient into the ward as per the need of patient. In the inclusion and exclusion criteria, ASA grade 2 and 3 are included, age 18 to 14 years, patients giving written valid and informed consent, normal singleton pregnancy, gestational age more than 37 weeks. In the exclusion criteria, the patient refusal, ASA grading more than 3 or major systemic disease, known allergy to studies drugs or local anesthetics, psychiatric illness, major coagulation abnormalities, infection at site of injection, chronic use of pain medication, morbidly obese patients, and anatomical abnormality. Pre-anesthetic evaluation of each case done 1 day prior to surgery with detailed history, general and systemic examination carried out with the presence of any systemic disorder. After obtaining informed valid consent, standard monitors like IV line secured, injection ondansetron 4 mg IV given as an antiemetic prophylaxis. Group 1 ESPP given in sitting position 3 cm lateral to T9 spinous process under all aseptic precautions under ultrasound guidance with using 0.2% ropivacaine, 0.2 ml per kg before lumbar puncture for spinal anesthesia. The needle tip was confirmed to be correctly positioned by injection of 1 ml of saline and visualize the linear fluid spreading between the erector spinae muscles and the transverse process. After aspiration to exclude vascular puncture, 15 ml of 0.2% ropivacaine were injected. The same intervention was performed on the other side of the back. Group 2 conventional analgesics conventional analgesic group, no block was performed. Only IV analgesics were given after shifting into ward as per the pain of patient, as per the demand of patient when patient complains of pain. Injection ropivacaine 0.5%, bupivacaine 0.5% hyperbaric 10 mg given intrathecally, strictly under all aseptic precautions in sitting position at L3, L4 space using 27 disposable spinal needle to all subjects following confirmation of spinal block by loss of sensation to pinprick surgery and surgery is started. Intraoperative vital parameters were recorded every 5 minutes for 30 minutes and then every 10 minutes till the end of surgery. Postoperative pain was assessed by VAS score and accordingly IV analgesics were given. Assessment of sensory blockade was done by pinprick method and motor blockade was seen according to modified Bromage scale. The observations and results are demographic data and diagnosis-wise distribution of the study subjects were comparable among two study groups. There was no statistical significant difference in preoperative, intraoperative, and postoperative mean pulse rate, systolic blood pressure, diastolic blood pressure, respiratory rate, and saturation in SpO2 in study subjects of ESPB group and control group patients. coming to comparison of onset of sensory block in all study groups, we observe that mean onset of sensory block was found to be 1.44 plus 1.44 minutes in ESPB group, and it is 1.97 minutes in control group. The difference in
Dr.
onset.
Sridhar, only 30 seconds left for you.
Okay, ma'am.
Please.
The comparison of onset of motor block is also comparable. Then coming to duration of analgesia in study groups, we observe the mean duration of analgesia in ESPB group was much higher in ESPB group than control group. Coming to comparison of VAS score, it at 0 hour, 2 hour, 4 hour, 6 hour, 12 hour, and 18 hours post-operatively. The significant difference of VAS score was observed. Coming to post-operative analgesic requirement, the post-operative analgesic requirement of injection tramadol, diclofenac, and paracetamol is also significantly less in ESPB group compared to control group. In discussion, the onset of sensory and motor patients who receiving ESPB block was earlier than control group. Duration of analgesia, post-operative VAS score in ESPB group are in duration of analgesia is more in ESPB group. Post-op VAS score is less in ESPB group. Consumption of analgesic in ESPB group is significantly lower in control group patients. Similar results as were found with other Malawat, Alisha, these studies which I have referred. Coming to conclusion, it was concluded that ESPB block provides more effective pain relief, longer duration of analgesic action, prolongs time of first analgesic requirement associated with less consumption of conventional analgesics, and also potentiates the onset of sensory and motor block of spinal anesthesia. ESPB is a novel, predictable, secure, and safe option for post-operative and post-cesarean section pain. Hence, based on its duration of action and effectiveness against conventional analgesic use, we should adopt ESPB block as default post-cesarean analgesia technique for post-cesarean section pain management. In addition, ESPB block would surely provide a clinical advantage in patients with substantial pain. These are my references.
Thank you, Dr. Sridhar. I would now invite judges to start the discussion.
Dr. Sridhar, your conclusion that it should be adopted as a standard procedure, that's rather harsh.
Ma'am,
rather harsh,
actually,
because
ma'am,
then I have too many points, and I'm sure all of us have too many points. But coming to one thing, I haven't understood. You said the onset of sensory and motor block was earlier. How is
yes,
that? I mean, you're giving
actually
the spinal. Just you're giving the ESP in sitting position.
Yes,
then you're giving the spinal in the same position, and then the patient lies down.
Not in the same position, ma'am.
No.
In sitting position.
Sitting. So when are you checking all this sensory, motor, then spinal effect?
Actually, the limitation of my study is that because
no, I'm asking you a straight question.
Yes, ma'am.
Yeah, I'm asking you. I'm not asking you the limitation. I'm just asking you, how did you do that? मुझे समझ नहीं आ रहा है कि you've given block, you've given spinal. Now, how are you checking the sensory motor of what? Of the block? Of the spinal? I haven't understood.
Actually, initially, before giving spinal, we have given this block bilaterally at the spinous process, T9 spinous process, 3 centimeter lateral to T9 spinous process.
You're just repeating me. I want the answer.
Yes, ma'am.
That's what I said. How are you checking, and what difference does it make, the sensory and motor block of the block? Because anyway, spinal is going to give you that block instantly.
Ma'am, actually,
what is the whole idea of doing this exercise? I have not understood.
Ma'am, the observation of my study is that means when I have observed the sensory onset and motor onset of both patients, means control group patient and ESPB patient, my observation of ESPB patient is that the onset and the onset of sensory and onset of motor is earlier in ESPB groups than control group. But I have not...
Of sensory and motor of what? The ESP or the spinal? or we don't know which one?
नो मैम, एक्चुअली ESP का सेंसरी हमने देखा ही नहीं मैम, क्योंकि ऑफ स्पाइनल, यस मैम.
How is
Because-
ESP going to change the onset of spinal?
On the basis of my observations, we can conclude that because of
You are
ESP.
See, listen, Dr. Sridhar, we need to understand that you can't jump to conclusion without any basis, you know?
Yes, ma'am. That
Can we?
I have mentioned in my limitation that though we don't have any similar studies, that onset of sensory and motor. In my observation, ma'am, I have observed these findings. That's why I have concluded that the onset of sensory and onset of motor in.
Sorry, I'm being very aggressive here, Dr. Sridhar, but you are a budding anesthesiologist and you have to first be convinced yourself of what you're trying to do, what you're trying to say. Okay, only
Yes,
then somebody else will be convinced and adopt ESP block as a default post-cesarean analgesia technique. Understood? So, I don't know if anybody in the audience can understand. Or maybe it's just me.
So Dr. Sridhar, basically,
I think, madam,
sorry.
I think the supervisor of the work, the person under whom he has worked, should be there to guide him
Yes,
and to
yes.
answer your questions. Because like this, the speaker is not aware, he doesn't know about it. I think preferably it should be made a point that the supervisor under whom the work has been done is also there in the audience so that he or she can answer it properly. This is my suggestion for future.
Yes, sir, absolutely. And having said that, I also believe, Dr. Sridhar, you must understand that, again, the same issue. Why are we doing the study? And what are we trying to find? That is not based on your observations. That is something that you decide when you're planning the study. And there has to be some literature evidence that supports what we do. We cannot do harm to our patients. Over to you, judges. Sorry, I just interrupted because I found it too difficult to hold on to myself. Sorry.
Dr. Sridhar, in your study, I had, like as you said, it potentiates the motor block or whatever. What is the percentage of ropivacaine you had used? Unmute yourself, please. You're muted. Unmute yourself. Yes.
Ma'am, 0.2% ropivacaine I can use in my study.
Okay. So we say, okay, it will potentiate. Is that the percentage which you use for motor blockade potentiation? I'm not going into the entire thing. I totally agree with Raki.
Ma'am, actually, ma'am, the motor and sensory blockade, onset of motor and sensory blockade is not my objective. The primary or secondary objective. It is the only observation I had found in this study. That's why I only enumerate these. Only I have to say the other things: duration of analgesia, then the consumption of analgesics
Whatever
requirement.
is your observation, I'm again going back. Will you see motor block potentiation with 0.2% ropivacaine? Straight question.
No,
yes
ma'am.
Or no?
Because 0.2% is no, ma'am. No, ma'am.
Second, do you
because
think
0.2% is only sensory?
Yeah. Do you think ESP will cover all aspects of pain in post-cesarean section? So coming back to the first question, like Anju Madam said, do you think that this block will be effective? What are the limitations of ESP that they have recently found?
Limitations, ma'am, pain control is in my study. I have observed that the pain control is much better.
I'm asking the limitations of ESP, due to which they are now saying that ESP is not that effective of late. So why is it? What is it? I'm not talking about your study. Since you have done a study on ESP, you should be really thorough on ESP before you present, right?
Yes, ma'am.
You're not sure of it. Okay. So you haven't studied pain on movement. It's only pain at rest that you have studied post-operatively.
Yes, ma'am. Yes, ma'am.
Okay, Dr. Sridhar, so few small queries. No, you had given ESP block with 0.2 ml per kg of local anesthetic, but
Yes, sir.
it is interfacial plain block and minimum volume will be 0.4 ml per kg to have a meaningful effect. So how did you decide on this 0.2 ml per kg of dose for the patients?
At the starting, when I have used a small amount of drugs, sir, the effect was not there.
See,
I have
what is the average weight of the patients you have taken in this study?
50 kg, sir.
50
kg.
kg. So 0.2 will come to 10 ml. So
sir, 10 to 15.
0.2 से तो 10 ही आएगा ना अगर 50 किलो वजन है तो.
Yes, sir. Yes. हाँ, sir. हाँ, sir.
So there is no study in literature which will recommend 0.2 ml per kg or 10 ml for ESP block. So probably it was not effective to begin with. Secondly, you said you had given the block 3 centimeter lateral. So
Yes, sir.
this means so from the midline, so I can give the ESP at 4 centimeter from midline, 5 centimeter. So this was 3 centimeter, at least 3 centimeter lateral or within 3 centimeters from midline.
Sir, actually 3 centimeter from midline.
So that is a line we make. So ESP should be within 3 centimeters, can be beyond 3 centimeter also. So if I give a block at 4 centimeter from midline, will it be an ESP block?
Actually, sir, I have hit the transverse process, and by withdrawing 1 mm from transverse process in that plane, I have injected the drug.
No, so actually you are not getting the question. So you are not aware of the ESP. The reason I'm asking is it will look the same. So if you put the ultrasound probe at 3 centimeter, 4, 5, so you have to make a difference between the rib and the transverse process. The change is very subtle. So you have to be really sure where you are putting in your needle. Otherwise, you end up in an intercostal nerve block. So which will not be as effective. So it will be limited to a single dermatome. Whereas where the ESP will be in the multiple areas because you are giving it a closer to the nerve root exit. So that is very important. The positioning of the needle when you're giving a block is important. Secondly, so why did you give the block? So you have given ESP for a post-operative analgesia, okay?
Yes, sir. Yes, sir.
And we know the spinal effect can last say up to about 2.5, 3 hours depending on what you give.
Yes,
so
sir.
why not give the block at the later stage? What is the fun of giving the block at the initial stage when the surgeon is also struggling? Many times it is an emergency. You're trying to get the patient done as soon as, because cesarean patients are tricky, for anesthetists as well. So we cannot take chances till baby is out. So why do you want to give the block at the initial stage after giving spinal? And secondly, in what position did you give the block?
In the sitting position, sir. I have given the
so that's
block
what
in sitting.
I wanted to hear. So once you give a spinal, you keep the patient sitting for about 20 minutes because it will take at least 20 minutes to give a ESP with ultrasound, even with an experienced hand. So the effect of block you want to achieve for a cesarean is what level you want to achieve? Dermatomal level of block for cesarean?
Sir, it's T10, T9, T10.
10 पे cesarean नहीं होगा बच्चे. You need at least T4 to T6 depending on you want
T6,
to do.
sir.
So
I have given at T9, but T6 will be T4 will be must.
No, you are confusing two things. I'm not asking about ESP now. I'm asking about spinal. So you have given a spinal block.
T4, sir.
So T4 you
Yes,
need.
sir.
So if you keep the patient sitting after spinal drug, whatever you have given for 20-25 minutes, it will be tricky to achieve that block in the required time. So that will be again another challenge.
But after immediately giving spinal, I have lied the patient down, sir.
तो फिर ESP block कब दिया आपने?
Before giving spinal, sir.
Okay, so you gave ESP first, and then you gave spinal.
And after that completion of ESP, then I have given spinal.
Okay, ठीक है.
How many of your patients had vasovagal? Because you sat the patient for as good as 20 minutes, and there is something called aortocaval compression, and there is pooling of blood in the lower limbs. would definitely cause some kind of vasovagal.
Ma'am, no one in my study.
मुश्किल है.
Amazing है.
चलो ठीक है.
चलो कोई बात नहीं.
That's why Dr. Sridhar, that's what, that's why my blood boiled in the beginning, because that statement, no, it should be adopted as a default, was really difficult to understand. Okay.
Thank you. Thank you, Sridhar. We can have the next presenter. So
Thank
Sridhar,
you, judges. That
all
was
the
a very
comments,
intense discussion.
all the comments are to improve you for future. Not we are not criticizing you because we want to criticize. So
सर एक्चुअली मैंने सर ये सेंसरी और मोटर जो है वो किसी भी लिटरेचर में मैंने देखा भी नहीं. जो फाइंडिंग्स मुझे दिखे उस हिसाब से, और अकॉर्डिंग टू वो ड्यूरेशन ऑफ एनाल्जेसिया, देन ऑल वास स्कोर एंड पोस्ट ऑपरेटिव, all were there, similar results were there with other people also, but sensory and motor का जो onset है वो मेरे ESPB में मैंने देखा, इसलिए मैंने वो वहाँ पे ऐड किया.
अगर मुझे ये स्टडी, to be honest, if I have to do this study for somehow, I'll first put the block in lateral position. I'll give a spinal first. The reason being that, and I have to be expert in ESP, because once you give a spinal, the pain of putting a needle of rectus spinae will be less. So you have to be you have to think about the patient, that you are giving multiple punctures in a pregnant patient. I will probably not do this the way you have done, but if I had to eventually do, so this will be the methodology.
Or maybe give at the end.
Best will be to give at the end.
In lateral position. Once
that will be best thing.
the cesarean is done, the bandaging is done, put the patient in lateral and take your time and do. There's no hurry, in the world. And you will have that 2.5 hours advantage, a huge advantage when your spinal is wearing off and this one is taking off.
And volume at least.
I want to ask
volume, of course.
20 ml at least each side. So 40 ml of local anesthetic. You can dilute as per the toxicity levels in that patient, but volume is important. You have to give
And
that.
I don't know how cesarean patients were just 50 kgs.
Sir, 50 to 55. Actually, there was not the patient was not more than 55 kg, ma'am. I have done total 76 cases, but there was no patient.
I
was
haven't
above
seen in my setup there is no patient 50 kgs for cesarean.
Actually,
Dr. Sridhar,
ma'am,
I think we
want
should
to
not
ask
take it
one
to heart. All of us are only trying to positively critique. It's not
Yes,
criticizing.
ma'am. Yes, ma'am.
Criticizing is a
Ma'am,
negative.
I want to
It will
ask
only
one
improve
question
yours,
because,
including all
ma'am,
the other
I want to ask one question, please, to all judges. Ma'am, may I?
हाँ, please पूछो.
सर, जो सेंसरी और मोटर का ऑनसेट मैंने मेरी स्टडी में देखा है कि इट इज सिग्निफिकेंटली लोअर, बिकॉज कंट्रोल में जो टाइम है तो जिसकी पी वैल्यू मेरी 0.05 से ज्यादा आई है, तो क्या ये मैं मेरे, बिकॉज दिस इज माय थीसिस टॉपिक सर, विच आई एम गोइंग टू सबमिट टुमारो, तो ये जो ऑनसेट ऑफ सेंसरी एंड मोटर का जो मेरा फाइंडिंग है, तो इससे इस कंक्लूजन पे मैं आ सकता हूँ या नहीं?
आपने रिकॉर्डिंग बिल्कुल जेन्युइनली करी है या पकाया है?
नहीं सर, मैंने जेन्युइनली किया है सर.
अच्छा.
ओनली द थिंग इज सर, एक कि यूएसजी गाइडेड नहीं दिया, मैंने ब्लाइंड दिया है.
तो आपको कैसे पता वो रेक्टस स्पाइन है, पैरावर्टिब्रल नहीं है या कुछ और नहीं है?
सर, that is my limitation.
That is a major limit. See, one theory which you can propose is.
अरे क्या सही डिस्कशन चल रही है, तो सोने से मत.
चलो, you can call me sometime, maybe we can discuss.
Okay sir, okay sir, okay sir.
Thank you, judges. I would now like to invite Dr. Anshika for her session. Over to you, Dr. Anshika. Please share your slides.
Good evening. I am Anshika Dendre, and I will be speaking on our study evaluating the efficacy of the gastrolaryngeal tube in ERCP. Traditionally, in our institute, ERCP, which involves diagnostic and therapeutic procedures of the biliopancreatic system, is carried out in the semi-prone position with the bite block in place while the patient is under sedation and maintaining spontaneous ventilation on supplemental oxygen via nasal prongs. The drugs given for sedation blunt airway reflexes, and sharing of the upper airway with the endoscopist further add to the complexity of the procedure. The gastrolaryngeal tube is a novel reusable supraglottic airway device with two separate ports for endoscopy and ventilation. As you can see, the device has a proximal cuff for stabilizing the tube and sealing the oropharynx, and a distal cuff to seal the esophagus to reduce gastric insufflation. Thus, advanced endoscopic procedures can be carried out under sedation without having to worry about losing control of airway safety. Keeping this in mind, our study aimed to assess the feasibility of the gastrolaryngeal tube for ERCP as an alternative to standard institutional practices. Ours was a prospective randomized controlled study lasting 1 year. Randomization was computer generated and allocation concealment was via opaque sealed envelopes. After obtaining approval from the Institutional Ethics Committee and CTRI registration, the patients included in our study belonged to ASA grades 1, 2, and 3 between the ages of 18 to 65 years of either gender with a BMI less than 30 kg per meter square and a height greater than 155 centimeters. They were then divided into two groups. Group G underwent ERCP after gastrolaryngeal tube insertion, while Group S underwent the procedure under sedation with the bite block in place. On the day of the procedure, after obtaining written and informed consent and confirming nil per oral status, standard ASA monitoring was attached, following which the patient was randomly divided into Group G or S. Patients in both groups were pre-oxygenated and pre-medicated with midazolam and fentanyl, following which injection propofol between 1.5 to 2 milligram kg was administered intravenously to patients in both groups, following which the GLT was inserted and the bite block placed in groups G and S respectively. Patients in both groups maintained spontaneous ventilation throughout the procedure at a propofol infusion between 50 to 150 microgram per kg per minute. Post-procedure, the GLT was removed and examined for blood staining. Over the course of the procedure, if the saturation levels to 92%, the oxygen flow rate was increased. Failing rise in saturation, rescue measures were undertaken. The sample size calculation for our study was based on a study by Terblanc et al., according to which our final sample size was 140, that is 70 patients in each group. The parameters observed and recorded by us were the success rate of the procedure, which was our primary objective, the number of attempts and time required for GLT insertion, the time to esophageal visualization, vital parameters, the total amount of propofol consumed, time needed to achieve a modified ALDET recovery score of greater than equal to 9, satisfaction scores of the gastroenterologist and the anesthesiologist, and complications. On analyzing our results, there was a 100% success rate in ERCP completion observed with the gastrolaryngeal tube with the device being successfully inserted in all patients in Group G. The device was associated with a significantly shorter esophageal visualization time. A significant steady increase in heart rate was noted in patients in Group S. The gastrolaryngeal tube was associated with statistically significant lower systolic blood pressure, diastolic blood pressure, and mean arterial pressure recordings. This could be attributable to a higher propofol requirement noted in Group G. Interestingly, in spite of a higher propofol consumption in Group G, the time taken to achieve a mean modified ALDET recovery score of greater than equal to 9 between the two groups was comparable. The device was associated with an increased ease of scope insertion and far greater scope maneuverability compared to the bite block. An abysmal finding was blood staining of the device in a sizable portion of the patients that underwent GLT insertion. With increasing complexity of ERCP, along with medical advancements, there's an enhanced focus on increasing patient safety and comfort. The gastrolaryngeal tube negates the need for endotracheal intubation for providing airway safety, leading to quicker recovery times in the absence of neuromuscular blockade. The device is associated with less increase in heart rate from the baseline as it provides a conduit for scope passage, thereby avoiding noxious stimulation of the aerodigestive tract. The gastrolaryngeal tube provides better endoscopy condition at the cost of unwanted sequelae. These were the limitations of my study. To conclude, the use of the gastrolaryngeal tube confers the advantage of less intraprocedural hemodynamic changes, quicker esophageal visualization, and better endoscopy conditions at the cost of increased propofol consumption and unwanted sequelae.
Excellent, Dr. Anshika. Very well presented in terms of presentation, content, and your study also is good. We've used GLT in the past. In fact, the reference that you've given, Srivastav and all, we've all part of it. We've used a lot, but we couldn't make it a standard practice because of the obvious reasons. One that you brought out, blood staining, and there is only one size of GLT available.
Yes, ma'am. So it can
How
only be
do you have many pieces with you? How do you do autoclave?
Yes, ma'am. We had 3 devices that we used in rotation, and we used to use plasma sterilization.
All right. And another thing, the desaturation in the other group where the support was not used. Did you bring out the
Ma'am,
SpO2?
there was no significant difference there was no clinically significant difference in saturation levels in either of the 2 groups, and there was no significant desaturation noted in the group that underwent the procedure maintaining spontaneous
Did you
ventilation.
find any leak in any patient, a major leak?
Actually, we did not measure the oropharyngeal leak pressure, and there was no leak noted in the sense there was adequate air entry, and the EtCO2 curve was.
And they were all in spontaneous, right?
Yes, ma'am. Both the groups, patients maintained spontaneous ventilation throughout the procedure.
Did anyone require assisted ventilation through the?
No one, ma'am.
No. And did you include the sick patients for ERCP? Because some of them are really sick.
Yes, ma'am.
Elderly, comorbidities, and sick.
Yes. No, patients more than greater, they're belonging to AC grades more than 3, and patients with MODS or at an increased risk of aspiration, or any patients that had any contraindications with supraglottic airway devices were excluded from our study.
Okay. So from study point of view, you have to exclude them. That's pretty good. But the actual use of GLT comes in these patients who are likely to desaturate or become unstable hemodynamically and still need to undergo an ERCP. So that's really nice, Dr. Anshika. Thank you so much.
Well presented, Dr. Anshika. I have a couple of questions. Who was the one who had inserted the GLT, yourself or your guide, or who was it?
Ma'am, my guide used to insert the device.
So he or she, whoever has inserted many more before this study was started, how many more?
Yes, ma'am.
Or is it the first time during this course?
No, ma'am. We had actually practiced inserting the device in mannequins prior to initiation of the study, following which we practiced inserting them in the controlled operating room environment. After that, we moved on to the non-operating room environment.
So what were the difficulties or complications that you observed during the course of the study during the insertion of GLT?
Ma'am, there is definitely a learning curve associated with the device. But we felt that in spite of a increased propofol requirement, there was comparable recovery time, and the recovery of the patients was quicker, and there were more stable hemodynamics throughout, as opposed to, when you need to sometimes give boluses during the course of the study when the patient is maintaining spontaneous ventilation and under sedation. As opposed to that, here there were more stable rate and more stable.
So
blood pressure
is stable in spite of the initial increase in the propofol dosage, you're telling?
Ma'am, the increased propofol dose is definitely required for being able to tolerate with the device, since it is a supraglottic airway device, it needs more propofol as opposed to just deep sedation with a bite block in place. However, one advantage the device confers is that because there is a conduit, as opposed to the bite block where there is multiple insertions of the endoscope and they keep maneuvering it all around, this provides a specific conduit. So there is less noxious stimulation and the patient also seems to be more comfortable at the end of it.
I'm sure you are very well presented. So I have two small queries. So firstly, so the problem with this gastric LMAs or LMAs used for endoscopy is that the procedurist is not happy. So they find themselves very restricted and they are not happy doing the procedure with LMA gastro or gastric DLT in place. So how did you overcome that problem?
Oh, sir, we actually also, one of the parameters studied by us was also the gastroenterologist satisfaction with both in both the groups, that is with the gastrolaryngeal tube as well as the bite block, where we asked them, we had an objective score in terms of ease of scope insertion, whether it was with resistance or were they unable to insert it, or did it go in easily, or with scope maneuverability, as well as overall procedural satisfaction and acceptability. And we found, especially when it came to ease of scope insertion, although that was more favorable in terms of the GLT, and the scope maneuverability was statistically more significant in terms of favorability with the gastrolaryngeal tube. This has also been a common factor in previous studies on the GLT and the gastro LMA. However, like the study conducted between gastro LMA and GLT, the GLT again had more favorable scope maneuverability. So even though that may seem to be an issue in our study, we got more favorable scores with the device.
Okay. And what was your primary objective?
Our primary objective was success rate of completion of ERCP with the gastrolaryngeal tube.
So that was 90% as per previous literature.
It was 99%, so previous literature, like completion of ERCP with gastrolaryngeal devices. So for our sample size calculation,
What is the routine success rate of endoscopy without a GLT?
So without the GLT, sir, what happens is one of the major adverse events that occurs in the non-operating room environment is actually hypoxia-related adverse event because of sedation. So which is where our supraglottic airway device comes in. So now if we use an endotracheal tube, that would be great because then our airway is completely protected. But with the supraglottic airway device, we don't need any neuromuscular blockage, so there is less recovery time. So it acts as a bridge between the two. So
the primary objective should have been the respiratory mobility, not the success, because success in any case, you end up doing the procedure somehow, whether you use a GLT or you use a sedation. So why you not specifically used the events which we are more worried about?
This was because firstly, we want to see if the gastrolaryngeal tube is a suitable alternative to the device. If we are unable to complete the procedure only with this device, then there is, it will be difficult to proceed further. As far as like when we conduct these procedures under sedation with the bite block, a lot of times they are abandoned because of hypoxia related adverse events, or they have difficulty in scope maneuverability, or there's increased complexity of the procedure. So the procedure becomes very long. So which again contributes to difficulty in tolerating the procedure for the patient. So initially this was just for, obviously further studies can be conducted to assess the feasibility of the device, keeping these objectives in mind. So this is a scope for further studies.
And by what is the method to deliver propofol in these patients? So did you use target control infusion or give intermittent boluses or infusion?
Initially we gave a slow intravenous bolus dose between 1.5 to 2 milligram per kg, following which we kept the patient on propofol infusion between like 50 to 150 microgram per kg per minute, which is misguided to based on the patient's requirement. We titrated the doses.
Okay, thank you.
I think the same point I was trying to bring, Anshika, what Dr. Nishkar said, the primary outcome could have been the respiratory adverse events. You know, that's why you're doing the study. Does it make your patient safer? As I said in the sicker ones, no? That's why we do. And initially, the endoscopists will have problems in maneuverability, then they get around. That's what we also saw. The
Yes,
number
ma'am.
of times they have to take the scope out. We noted that also in the study, the number of times the scope had to be taken out because of desaturation. Because, you know, in the absence of that, you had to put the mask on or intubate or whatever. So they had to take the scope out, which is quite distressing for them and makes the whole process longer. Yeah.
What I meant to say was 100% success rate, including everything, in the sense that whether it was, you know, the procedure had to be abandoned for any reason, and then it was actually comparable.
Interrupted. Usually it's not abandoned, interrupted, I would
Yes,
say.
ma'am, exactly.
In extreme cases, abandoned.
Yes.
Sir, you wanted to say something, sir.
I want basically in ERCPs, you see there are different type of ERCP procedures. One is either removal of retrieval of a stone or sphincterotomy, or then there can be associated procedures with ERCP. So my one question is that what was the procedures performed? ERCP is a very wide term. You can have retrieval of one stone, two stones, taking biopsies and with ultrasound guided and other things. That is all ERCPs, stent insertion. So number one, listen to me. Number two is that you should compare between the device and without the device. How much is the time taken for the procedure, for a particular set of procedure? How much time taken between with the device and without the device? And the amount of the drug which has been consumed by the patient. Time taken and the amount of the drug consumed by the patient and the condition of the patient at the end, immediately at the end of the procedure. What is the level of the consciousness and what is the other conditions? They are the most important when you are doing ERC procedures like ERCPs. These are the things to be kept in mind. The duration of the surgery, the amount of the drug consumed, condition at the end of the procedure, and what is the procedure performed. ERCP is a very wide term.
Yes, sir.
Thank you.
So we stuck to procedures of the biliopancreatic system, which may include therapeutic biliary drainage in the form of stenting or stone removal, or therapeutic biliary pancreatic drainage, where we do pancreatic duct stenting, or also palliative pancreatic drainage, in the sense like prior to performing a PD. Then the time taken for the procedures was also calculated by was also taken into account by us, but they were found to be comparable in both groups. And the level of consciousness was actually assessed by the modified Aldrich recovery score. So once it was greater than or equal to 9, only then the patient was shifted to the PSU. And in spite of a higher propofol requirement associated with
Was there any difference in the duration time taken by the procedure? Any difference in the total consumption of the drug? Any difference in the Aldrich score at the end of the procedure? These are the three main important things when you are going to perform ERCP. That will lead you somewhere. If it doesn't help you, there is no fun.
Yes, sir. Sir, the gastrolaryngeal tube.
I hope you have got my point.
Yes, sir. Yes, sir. The gastrolaryngeal tube had higher propofol requirement, but there was no significant difference in the time taken to achieve a modified Aldrich recovery score of greater than or equal to 9. Now, although the duration of the procedure was found to be comparable in the two groups, the gastrolaryngeal tube was associated with a significantly shorter time taken to visualize the esophagus. It was compared to around 4 seconds, compared to around 8 to 9 seconds in the without the GLT.
Normally, how much time does your gastroenterologist take in performing ERCP on an average per patient?
Sir, around it depends on the procedure. For therapeutic biliary drainage, takes around 20 to 25 minutes. However, if the anatomy is very difficult, it may take up to 45 minutes.
You said 4 seconds and 8 seconds. In
Yes,
a procedure of half an hour or 20 minutes or 30 minutes, 4 seconds or 8 seconds doesn't matter unless there are any respiratory problems. If the patient is going to hypoxia, if the patient is struggling, if there is some trauma, all these things. Otherwise, 4 to 8 seconds doesn't matter. I leave it to the judges. I leave it to the judges to talk further. I wanted just to make this point. Thank you.
Thank you, sir.
Thank you, judges. Do we have any more questions, ma'am, sir?
No, maybe we can proceed.
Okay, yes. Okay. So I'd like to invite Dr. Neha Kumari for her presentation. Over to you, Dr. Neha.
Is my screen visible?
Yes, it was visible. Can you please share your slides? We can see your video. Please start your screen sharing.
Is it visible now?
Yeah, it's visible now.
Yes.
Good evening, everyone. Today, I'm Neha Kumari, Dr. Neha Kumari from Dr. RML Hospital, and I'm going to present my thesis paper, whose title is Comparison of Effects of Cisatracurium and Atracurium upon tryptase, IgE levels, and absolute eosinophil counts in adult patients undergoing general anesthesia for elective surgery. As we know, atracurium and cisatracurium are the two non-depolarizing neuromuscular blocking agents, which are also stereoisomers. They have different histamine release profiles, which is reflected as rise in serum tryptase, serum IgE, and absolute eosinophil count in blood. So in our study, we compared total lab values of these three serum levels of serum tryptase, IgE, and absolute eosinophil counts, and the clinical features of histamine release by the two muscle relaxants. Now, as we can see, histamine release can be detected as the following clinical features: skin flushing, hypotension, tachycardia, decreased systemic vascular resistance, bronchospasm, increased airway resistance, and anaphylactoid reactions. In our study, the aim of our study was to compare effects of cisatracurium and atracurium upon serum tryptase, IgE, and absolute eosinophil count. And my primary objective was to compare the effect of cisatracurium and atracurium upon serum tryptase levels in adult patients undergoing general anesthesia for elective surgery. And the secondary objective for my study was to compare the effects of cisatracurium and atracurium upon serum IgE levels, absolute eosinophil counts, hemodynamic parameters, and clinical side effect profile. This study was conducted in the Department of Anesthesia and Department of Biochemistry in Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital, New Delhi. The study design for my study was to randomized prospective observational study. It was conducted from 1st Jan 2021 till 31st May 2022. The sample size for my study was 80, that is 40 in each group. Inclusion criteria for my study is to consenting individuals, adults of age group 18 to 60 years, and patients with ASA grade 1 and 2, modified with modified Mallampatti's grade 1 and 2. I have excluded the patients with anticipated difficult airway, peripheral neuropathy, diabetes mellitus, neuromuscular disorders, and myopathies. Then with patients on antibiotics, example, aminoglycosides, tetracycline, bezitracin, lincomycin, clindamycin, etc. And drugs with like magnesium sulfate, lithium, procainamide, and quinidine. And patients with history of atopy and asthma or any known allergy to any of the two drugs in previous surgeries. And I also excluded the patients who are pregnant. The statistical analysis was based on a study which was my reference study, Garvey et al. In 2010. The sample size was calculated by assuming a difference of 0.5 microgram per liter in serum tryptase as significant, and the proposed sample size calculated was 31 patients per group, which was necessary to be to detect any significant changes. The effect size of 0.70 was taken, and alpha 0.05 was taken, and power of 80% and power. Then using this sample size calculation formula, the statistical analysis was done. Sample size calculation was done. Now coming to methodology. After a thorough pre-op evaluation and prior consent, 80 adult patients of ASA class 1 and 2 were divided into two groups of 40 each by computer-generated randomization, and group 1 received injection cisatracurium 0.15 mg per kg and top-up doses at 0.03 mg per kg. Group 2 received injection atracurium 0.5 mg per kg and top-up dose at 0.1 mg per kg. My anesthesia technique was, the patient was taken in OT, standard ASA monitors along with neuromuscular monitoring and BIS monitoring was attached. Intravenous access was established. The patient was pre-medicated with injection midazolam 0.03 mg per kg IV and injection fentanyl 2 mics per kg. Pre-oxygenation was done with 100% oxygen. The induction was done with injection propofol 2 mg per kg IV, and the baseline TOF was recorded before giving the respective neuromuscular blocking drugs. Now, before induction, we have taken a baseline blood sample in 3 separate vecutors for serum tryptase, IgE levels, and absolute eosinophil count. In our study, in group 1 received injections cisatracurium 0.15 mg per kg IV, and group 2 received injection atracurium 0.5 mg per kg IV. At the NO4 score of less than equal to 2/4, intubation was performed. And maintenance of anesthesia was done with a mixture of oxygen 50%, nitrous oxide 50%, and isoflurane titrated to maintain a MAC of 1. And depth of anesthesia was also maintained by evaluating the BIS score in the range of 40 to 60. The blood samples were taken 2 ml each in 3 separate vecutors, 1 each for total IgE, serum tryptase, and absolute eosinophil count, 1 hour after the study drug was given at the time of induction, and 2 hours after this drug was given. And additional samples were also taken if and when side effects occurred. Now, continuing this anesthesia technique, I've monitored the TOF during the surgical procedure, and top-up of was given at the TOF of more than 2/4. Injection cisatracurium was given 0.03 mg per kg in group 1 and injection atracurium 0.1 mg per kg in group 2. Reversal was done when the TOF of more than equal to 3/4 was attained and the surgery has been completed, and extubation was done when the patient became fully awake, was obeying commands. Clinical features of histamine release were also looked after 4 hours of the first dose of muscle relaxant. Now, method of blood test which we used are ELISA kits. For serum tryptase, IgE test was also done by total IgE ELISA kit, and absolute eosinophil count was done by automated hematology analyzer 5 parts Sysmex X1000. Now,
only 30 seconds left, please.
Yes, ma'am. Comparison of demographic characteristics was shown in the bar graph. Mean age and weight is shown in sex distribution. In the next, I have shown the mean serum tryptase levels at different time points in both the groups, and the comparison of serum IgE levels in this graph, and absolute eosinophil count, and heart rate, and systolic BP, diastolic BP, and MAP between the two groups. The observation and discussion, the demographic profile of both the study groups were statistically similar, and baseline of serum tryptase, IgE, and absolute eosinophil counts between the two groups were similar, and according to the p-values which has come, it was insignificant. And post-induction, similar results were there in all the three parameters, serum tryptase, IgE, and absolute eosinophil count. And according to the p-values, it was insignificant. 1 hour post-induction, the change in mean serum tryptase, IgE levels, and absolute eosinophil count according to the p-values was similar and insignificant in both the groups. The heart rate, SBP, DBP, and MAP were also similar. Now, concluding my thesis paper presentation, age, sex, and weight were matched for both groups. The depth of anesthesia were good, similar in both the groups as per BIS values, baseline serum tryptase levels, IgE levels, absolute eosinophil count, hemodynamic parameters were similar in both the groups. All three serum tryptase levels, IgE levels, absolute eosinophil count increased at 1 hour of induction, but was statistically insignificant between the groups. Heart rate values were comparable between the groups at post-induction and 1 hour post-induction and statistically insignificant. In a study, the 3 markers of histamine release were found to be similar in both the groups. Limitation of my study was that it was a single center based study and also only ASF 1 and 2 patients were included and direct histamine measurement kits were not available for this study. My references are these. Thank you. Now I'm open to questions.
Yeah, Dr.
Yes,
Neha,
Dr.
thank you. It was very nice, and Rsacp is trying to get into our practice, and maybe you are helping in it. Simple thing, how did you collect all those samples? It must have been during the surgery, right?
Yes, yes, ma'am. I've carried my vacutainers with me. In each case, I have went and collected my samples. A baseline sample was collected after the patient was induced, just propofol was given. So I collected the first sample as baseline. Then I have collected the other sample.
So understood. But how you made multiple pricks each time? How many times the samples were collected?
First prick was by cannulation. First, I used the cannula, which was for baseline sampling. Then other was from the other hand elbow, cubital region. So it was with the
a total of how many samples?
I have collected in cases of lab cholecystectomy, mainly elective surgery. So it was the duration was approx 2 hours. So I have collected only 3 samples total. Only 2 additional pricks were made.
But lab cholecystectomies must be getting over in half an hour, 40 minutes.
1.5 hours, some cases extend. So, and some cases were also, not only lab chole was taken, I have taken in the lab appendicectomy also, and other cases also, which were ASA 1 and 2 grade. Patients were ASA 1.
Okay. So you think we should start using Rsacp in all our cases, or where we are suspecting a problem with atracurium? After studying so much, what do you think?
Yes, ma'am, we can start because it is a very effective drug. It is very effective, and the duration of action, which after the first drug was also prolonged. I have seen in many cases 90-minute surgery. The surgery completed and only 1 dose I have given. So
the intubating dose.
Intubating dose only. It was so potent because it is 4 to 5 times more potent than atracurium. The dosage
is also less.
And the laudanum releasing metabolite is also less in this. So in a clinical range, dose range, we can give Rsacp and it is better as compared to atracurium.
And cost-wise also, it's not very expensive.
It is not very expensive. If it is in government supply, we can.
Okay.
So Neha, what was your research hypothesis for the study?
Ma'am, sir, my hypothesis was that the Rsacp is comparable to atracurium in with respect to serum tryptase levels and serum tryptase, Ig, and absolute eosinophil counts. Effect and clinical side effect profile is comparable to atracurium. And
why do we think that it's comparable? No, we know cisheterogram will be better.
yes,
So that could be
because
null hypothesis, but not research question, no?
sir, in our hypothesis, we actually were writing the thesis, so we have to show the drug to be comparable, not better. We have to hypothesize like that. So null hypothesis.
So,
Yes.
okay. One more challenge with this both cisheterogram and heterogram is that you have to have a very good temperature
Cold.
control.
Yes, sir. Yes, sir. I
And
maintain
that's the challenge in
cold
our,
chain.
especially in the summer months. So, how did you ensure that good quality drug was used in all the patients?
Yes, sir. I only brought the drug from the refrigerator, where I have kept it, and the temperature of 4 degrees Celsius temperature level only. And then after, when we are inducing the patient, then only I loaded the drug and given in our OTs.
Okay, thank you. Dr.
Well
Vijay.
presented, Dr. Neha. So as you said, it would be beneficial since the cost is same or something. Did you analyze it in your
Yes,
study,
ma'am.
cost benefit analysis?
Ma'am, in our study, we were concentrating on serum tryptase, IG, and absolute eosinophil count and clinical profile. So I have not shown the cost benefit, but it can be published. When I am publishing, I can show it that it is cost effective. It is similar. Cost is not that much if we are introducing in the government supply, ma'am. It is my thesis. In my thesis, I have indented my drug by the permission of pharmacology department.
Government or private?
Yes,
The
yes, ma'am.
suggestion is you already have how much mg you have used in each case, right? So you
Yes, ma'am.
already know the total dose and you
Yes,
can
ma'am.
always calculate the cost
Yes,
in the
ma'am.
cases probably and do an
Yes,
analysis right now. Since you have the
Yes, ma'am.
data, you didn't do
Yes.
that aspect initially, probably you can add on. And what is the final conclusion that you want us, all of us, to take away point from your study?
Ma'am, the final conclusion is that if both the drugs, cisheterogram and heterogram, are comparable in results on the basis of serum tryptase and IG and absolute eosinophil counts, which are the histamine markers in the blood, so we can use cisheterogram in place of heterogram, and it is better in terms of potency, so we can replace the heterogram in place.
Your reference studies, this in the discussion
ma'am.
which you have told,
Yes,
what
ma'am.
is it that your study adds on to the
Adds on.
existing studies?
Yes,
Do you
ma'am.
also say the same thing, or your study
Yes, ma'am.
adds on something?
Yes, ma'am. It adds, ma'am. Yes, ma'am.
Adds on that there
Adds
is
on.
no difference. The other
There
studies
is no
in your
difference.
discussion have shown that there is a difference among both of them in respect to the serum tryptase and all, right?
Ma'am, only a minimal, insignificant result was there in one of the studies that I have referencing. That is Garvey et al. In 2010. They have. It was insignificant actually. It was not that significant level of rise because they also took the dose range, clinical dose range, not in a higher dose. So it was insignificant.
One more small suggestion, probably not only to you, to everyone. Don't just go take your results by the p-value. Go beyond,
Yes, ma'am.
go to your statistician. P-value alone won't tell much. So significance or non-significance, you have to go beyond it, go for the confidence intervals, present it much better with your, to all the students, I mean, not to you alone. I would like to make that suggestion. Thank you.
Thank you, ma'am.
Thank you, judges. I would now like to invite Dr. Sambit for his presentation. Over to you, Dr. Sambit.
Yes, ma'am. My screen is visible, ma'am. Hello?
Not
No.
yet. Not yet. It's not visible.
It is visible, sir?
Yes, it is. You can
Make it
turn
full screen.
Yes, sir.
Presentation mode.
Yes, sir.
Video is not visible, Sambit.
Yes, sir. I have on my video.
नहीं, आपका वीडियो आ नहीं रहा है. हाँ, अभी भी नहीं आ रहा. नहीं.
Sir, I have switched on my video, sir.
It is not coming, so maybe you can start. We should not waste time.
Okay, sir. So good evening, all. Coming to my paper, it's the evaluation of a new parameter, that is the tongue thickness to the oral cavity height ratio on airway ultrasonography in prediction of difficult intubation and laryngoscopy in patients with unanticipated difficult airway, a prospective observational study. My guide is Dr. Aparita Panda from AIIMS Bhubaneswar, and my co-guide is Dr. Nitasha Misra from AIIMS Bhubaneswar. Coming to the introduction, airway evaluation is crucial during the pre-anesthetic examination. Although clinical tests have been used to predict the difficult airway, still there is 1.5 to 13% of cases are still complicated by unanticipated difficult laryngoscopy. Nowadays, ultrasonography has evolved as a new technique for airway assessment and anticipating difficult laryngoscopy. In this study, we aim to test a new parameter, that is the tongue height to the oral cavity height ratio with other anterior neck soft tissue measurements to predict difficult laryngoscopy as well as difficult intubation. Under the aim of the study, evaluate the role of the new parameter, that is the TT-OHR, and various other ultrasonographic airway parameters in predicting difficult laryngoscopy and intubation in patients with unanticipated difficult airways. My primary objective is to establish the correlation between the ultrasound measurements of the airway with difficult laryngoscopy, which is defined as the CL grade more than 2B, and difficult intubation, which is defined as more than 3 attempts of intubation by an experienced intubator. And my secondary objective is to determine a cutoff value for the above measurements. Coming to the methodology, the prospective observational study was conducted in the Department of Anesthesiology and Critical Care in AIIMS Bhubaneswar between July 2020 to September 2021 after getting approval from the Institutional Ethics Committee. My the inclusion criteria includes adult patients from age 18 to 65 years who require tracheal intubation for elective surgery under general anesthesia, belonging to ASA grade 1, 2, and 3. The exclusion criteria includes the patients who refuse to give consent, patients who require fiber optic intubations, patients with anticipated difficult airway, and in whom USG is not feasible. This is the methodology in which I have taken the ultrasound via linear probe in both longitudinal as well as the transverse section to get the various ultrasound measurements of my thesis. Here in the right side first picture, the figure 2.1, I have taken the base of the oral cavity by linear probe in the transverse section, in which the tongue height is defined as the height from the base of the tongue to the thickness of the tongue. That is this height is the thickness of the tongue. So I have taken the tongue height. Then the oral cavity height is taken as from the base of the tongue till the hard palate, and I have taken the ratio, that is the right red area divided by the blue area. Similarly, other parameters like the skin to hyoid bone distance, skin to epiglottis distance, and skin to thyroid membrane distance are also taken in my study. Statistical analysis, sample size of 120 was required to construct a ROC curve with the area under the curve being 0.75, assuming the incidence of unanticipated difficult airway, difficult intubation, and difficult laryngoscopy to be 10%, with the power of the study assumed to be 80% with an alpha error of 5%. The correlation analysis was done using Kendall's tau test, and the ROC curve was used to determine the sensitivity and the specificity of the measured ultrasound distances. Also, the ROC curve was used to calculate the cutoff values for the USG parameters, and the differences were considered as statistically significant if the p-value is less than 0.05. The results, a total of 120 patients, including 62 females and 58 males, were included in the study. The incidence of difficult laryngoscopy was 24%, and the incidence of difficult intubation was 12.5%. All the ultrasound parameters showed positive correlation with difficult laryngoscopy, with TT-OHR having the maximum correlation. That is the tau value, Kendall tau coefficient is 0.555. From the receiver operating curve, which will show next, the best predictor of difficult laryngoscopy is that is CL grade more than equal to 2B was TT-OHR with the area of the curve, area under the curve 0.941 and a 95% confidence interval of 0.87 to 1.0 with a cutoff value of 0.79, which is having 90% sensitivity and 92% specificity. Similarly, the best predictor of difficult intubation was TT-OHR again, with the area under the curve 0.926 with a 95% confidence interval of 0.8 to 1.05 with a cutoff value of 0.811, which is having a sensitivity of 93% and specificity of 99%. This is the correlation between the airway parameters, that is what the 4 parameters which I have taken along with difficult laryngoscopy. So here all the parameters showed positive correlation with difficult laryngoscopy, and among which skin to the tongue height to oral height cavity ratio as well as the skin to epiglottis distance, these two have maximum correlation, and the TTOHR is having the best correlation. This is the receiver operating characteristic curve of the parameters, ultrasound parameters predict against the difficult laryngoscopy, in which the x-axis shows 1 minus specificity as the false positive rate, and the y-axis shows the sensitivity, in which we can see the TTOHR is having the maximum sensitivity as well as the maximum specificity as well as the maximum area under the curve. So this predictive accuracy of this parameter is best among all the 4 parameters for predicting difficult laryngoscopy. In this curve, I have shown the ultrasound parameters for predicting difficult intubation. In this curve, although the skin to epiglottis distance, that is the red curve, which is having maximum sensitivity, but when comparing the 4 parameters, the TTOHR again has maximum sensitivity as well as specificity, and the area under the curve is again higher. So coming to the discussion, most of the studies have analyzed the role of tongue thickness and volume for predicting difficult airway. And the difficulty arises because the tongue, because it not only depends upon the tongue's thickness, it depends also on the tongue's displaceability on the floor of the mouth. So whenever we are, so in this study, you have used the tongue height to the oral cavity height ratio, and it acts as a surrogate sonography marker for monolymphatic grading in prediction of difficult airway. And till date, no other studies have taken and tested this ratio. Although there are studies which have tested this individual parameters, tongue volume or tongue thickness, but no study has taken the ratio. Simply using tongue thickness may not have a diagnostic role. So the addition of a oral cavity along with its ratio may increase the sensitivity as well as the specificity. Also during laryngoscopy, we are displacing the tongue downwards, that is from upwards to downwards. So the tongue height or the tongue thickness could be the best measurement in assessing the difficult airway rather than tongue volume, which is a 3-dimensional parameter. So coming to the strength of the study, here we have included head-to-head comparison of the various ultrasound parameters and the introduction of a newer one also. And the limitations include smaller sample size. The value may not hold true for pregnant and obese population, which are excluded from the study. And the tongue is a very mobile structure, so there may be intra-observer as well as the intra-observer variability. So concluding my paper, the ratio of the tongue thickness to the oral cavity height using ultrasound is both a sensitive as well as a specific predictor for difficult airway, with a cutoff value of 0.79 for difficult laryngoscopy and a cutoff value of 0.81 for difficult intubation. These are my references, sir. Thank you, sir.
Thank you, Dr. Samvid. It's open for discussion, and I would like the judges to start the discussion, please.
Yes, ma'am.
I think, Dr. Samvid, you've done a very interesting study and brought this ratio into play, which makes a lot of sense. And so you said only one person did all the scans, right?
Sorry,
only one person did all the scans.
One person, ma'am. Actually, ma'am, I have done all the scans.
Okay, you have done. Okay.
Yes, ma'am. Ma'am, initially I have done it on 50 patients, for which I am the initial learner. And after I mastered the ultrasound of doing the airway ultrasound, then I have started my thesis.
That's nice. That's nice. We can't see you.
Ma'am, actually I have on my video, ma'am. It's not working.
Okay, it's okay. So besides the technical points of the research design, you think after having done that initial 50, you think it's easy to do, it takes time, there's a learning curve?
Yes, ma'am. Ma'am, in this study also I have done a learning curve. I have not included in the slide. I have prepared a learning curve in which the growth, the curve is much better. Like I have taken the time taken for doing the ultrasounds. Initially, I have taken around 400 to 500 seconds for doing all the measurements, that is all the 4 measurements. And when concluding the study, when I have done the 120th patient, the time gradually comes down to 150 to 180 seconds. So I have done a
One is the time, second is the accuracy. You have to be sure that this is the tongue top to bottom, this is the oral height. You
Yes,
know,
ma'am.
I think accuracy and precision here is more important than time. A
Yes,
few
ma'am.
seconds here and there won't matter, maybe a minute won't matter, but the precision would definitely matter. And so, it's very interesting that a non-invasive way to check. So this you're doing on table, right?
Yes, ma'am, on table.
Not
After
in
I bring the
pre-op.
patient, yes, ma'am. In the pre-op area also we can do, but we generally shift the patient to the theater and on table. After attaching the monitors, I usually do this ultrasound, and we can have a rough idea of whether the patient is going to have a difficult laryngoscopy or not.
Yeah. So at the end of your study, what you have recommendation or you have conclusion for
Ma'am,
the
that's my
readers?
study's conclusion, ma'am. What I found in my study, and that's what I have told, ma'am. Like for difficult laryngoscopy, the cutoff is 0.79, and
Yeah,
for
I know. So you have concluded that this is this, but do you recommend
Yes, ma'am.
beyond
This is a
your
very valid test, ma'am, because this is the surrogate method of Mollampati grading, and we have done 100%, 100 Mollampati grading in 100 patients. Still, we don't find in unanticipated difficult airways. We still find 24% patients with difficult laryngoscopy. So this is a valid test, and it's a non-invasive test, and it doesn't take much time. It takes 3 to 4 minutes maximum for a new learner. So we
But
can.
besides Malampati, there are other very important ways. I mean, more the stronger ways to predict difficult airway.
Yes, ma'am. All these things, ma'am, I have taken in the PSC clinic. Once we are doing the pre-anesthetic checkup, and once the airway assessment was done, the patients who were categorized as unanticipated difficult airway, only those patients are taken, ma'am, for the study.
Okay.
Yes, ma'am. Thank you.
Thank you.
Very good study, Dr. Sambit. So how did you check for the base of the tongue? Checking the tongue thickness.
Ma'am, once I put the linear probe at the base of the oral cavity, we see the whole of the oral cavity, and the muscles, that is the genioglossus and the myoglossus muscles, which makes the bulk of the tongue, we take it as the tongue thickness. And again, from the base of the tongue till the palate, hard palate, that is taken as the total height of the oral cavity. And we are taking the ratio of the two, ma'am.
Only one ratio you felt was giving this prediction. Did you try any other combinations of other, say, skin to the hyoid bone and versus?
Yes, ma'am. I have taken 4 parameters. I have taken 4 parameters like skin to epiglottis distance, skin to hyoid bone distance, skin to thyrohyoid membrane distance, and this ratio. But out of these 4 parameters, ma'am, these last initial 3 parameters are being used in the previous studies. And in this study, I have included this ratio as a novel parameter.
No, I'm asking here, you're saying tongue thickness to oral cavity height ratio. Yes, the others are a single digit. They also parameter. Ratio between of the tongue thickness to skin to hyoid, skin to thyroid, all of those?
No, ma'am, we have not included those things. We may try it, ma'am.
Yeah, now also you can try. You already have the values with.
Yes, ma'am. We have. We may try. I'll definitely try for it.
What was the average body weight of the patients overall?
Ma'am, BMI 18 to 25, ma'am. We have taken BMI 18 to 25.
Very ideal.
Yes, ma'am.
Shambit, my question is, so there is an interesting study, and every time we are now gradually moving towards ultrasound for assessment of airway in the pre-operative period. However, till date, there is no clear cutoff available to decide that it is difficult, what is difficult and what is not.
Yes, sir.
But the initial assumption you made for the sample size calculation that unanticipated difficult airway is 10%.
Yes, sir.
Is too high, I believe, because we don't find too common finding that we don't anticipate and you end up in an unanticipated difficult airway. It is one of the rare events. So what made you decide to take this 10% as unanticipated difficult airway, that too in patients who have a normal BMI, say 18 to 25, lean thin patients, no other comorbidity, no facial deformity. So you don't expect.
Yes, sir.
So initial assumption for sample size calculation, I fear, appears to be wrong.
Yes, sir. Sir, actually, we got this idea from a European journal, which have done actually this airway ultrasound study for predicting difficult laryngoscopy. In their study, it was 1.5 to 13%. And then we have compared it with our hospital data. In AIIMS Bhubaneswar, till date, we have collected the data and we have seen how many difficult laryngoscopy, difficult intubation cases are there, and it is roughly around 8 to 10%. So that's what
It is unlikely. So what do you call difficult? No, my next question will be, what is difficult for you in your hospital or in the European study you are quoting? So
yes, sir, yes, sir. Like for difficult laryngoscopy, you had taken it as CL grade more than equal to 2B, sir.
No. And you are doing a direct laryngoscope for laryngoscopy?
Yes, sir.
So this is a difficult laryngoscopy, not difficult intubation?
Sir, I have made my sample size calculation based on the difficult laryngoscopy value, sir. And then I have extra calculated the difficult intubation values and cutoffs.
No, I don't. The assumption looks little this thing, and 10% means 1 in 10, which is too much. So it is usually 0.1, 0.2, 0.3% if you had I believe that probably for a reasonable sample size you had made this assumption. So 10% appears to be too high for this thing. You will get this query if you send for publication.
Okay, sir. Thank you,
Who
sir.
did all the intubations? You yourself?
Sir, yes, ma'am, my senior resident who is posted in the theater. Then
Single person in all 120 cases.
No, ma'am. Actually, I have done all the ultrasound. And I am posted in which OT I will do the ultrasound, and the senior resident posted in that OT, they will do the intubation for the particular case.
So essentially the question is, so there were multiple hands doing the intubation. No, different people have different ways of doing, and they have different.
Variability.
Yes, sir. Yes, sir. That's the limitation, sir. You have intra-observer and intra-observer variability of this collecting data, sir.
Okay. And you used a video laryngoscope or a normal laryngoscope? DL?
The normal laryngoscope.
Normal.
Macintosh.
So other person cannot judge the views. Okay.
Okay. Thank you, sir.
Okay.
Thanks.
I would now like to invite Dr. Charan for his presentation. Over to you, Dr. Charan.
Am I audible now?
Yes, you're audible, Charan.
Good evening. Today I'll be presenting on, I'm Dr. Charan and I'll be presenting on the topic of comparative evaluation of efficacy of platelet-rich plasma.
Dr. Charan, we can't see your slides. Can't see your presentation.
Dr. Charan.
Is it visible now, ma'am?
No, it's not visible.
Not yet.
आपकी स्लाइड्स नहीं दिख रही हैं, आपकी आवाज आ रही है ना, आपका वीडियो दिख रहा है.
वीडियो भी नहीं दिख रही.
Dr. Charan, share your screen, please. Press the green button in the middle of the screen.
Yes, sir. Yes, I've done it, sir.
Yeah, okay, I can see you now.
आपका वीडियो दिख रहा है, अब आप स्क्रीन दिखाओ.
Is it visible now, ma'am?
No, नीचे green button लिखा हुआ दबा हुआ है, share screen का वो दबाइए.
सर दबा रहा हूँ सर, वो शेयर स्क्रीन आ रहा है.
नहीं फिर ऐसे कैसे हो रहा है?
फिर आप उसके ऊपर आप अपनी पीपीटी जो खुली हुई है क्या आपकी, उसके ऊपर क्लिक कीजिए.
हाँ जी सर, यही पर खुल रहा है सर मेरा.
हाँ, नहीं दिखाई दे रही.
Just a minute, ma'am. I'll just close it and. Is it visible now, ma'am?
We can see a video, but not your screen, not your slides.
Do we have the next candidate with us, Dr. Vishali?
Yes, just.
नहीं आपका आप देख लो, we can have the other one ना, if you have the other candidate.
Okay.
Okay. Dr. Vishali, can you please start sharing your slides?
Yes, ma'am.
Over to you, Dr. Vishal.
Invisible, ma'am?
Yes, it's visible. Please go ahead.
Good evening, respected panelists and judges. My name is Dr. Vaishali Phogat, and the presentation the title of my presentation is to compare the radiofrequency thermocoagulation of ganglion impar with block using a combination of local anesthetic and steroid in chronic perineal pain. The study was carried out under the guidance of Dr. Naveen Malhotra at PGIMS Rohtak. So chronic perineal pain is anorectal and perineal pain without the underlying organic disease. It may be idiopathic, benign, and malignant. Benign causes include functional disorders of the pelvic floor muscles, accompanied by perineal pain, coccytodynia, chronic prostatitis, proctitis, pudendal neuralgia, vulvodynia, vaginismus, etc. The malignant causes include the carcinoma of pelvic and perineal region. The conservative treatment for benign chronic perineal pain includes massage, hot baths, muscle relaxant, electrogalvanic stimulation, and biofeedback training. Whereas in cases of patients with frequent symptoms, drugs such as inhaled beta-2 adrenergic agonist, salbutamol, or alpha-2 agonists like clonidine, nifedipine, or topical nitrates are used. In severe cases, persistent pain is treated with low epidural anesthesia, IV lidocaine, local injection with botulinum toxin type A, ganglion impar block with local anesthetics alone or in combination with corticosteroids, alcohol or phenol neurolysis, and radiofrequency thermocoagulation. The ganglion impar have been carried out. The ganglion impar is also called as ganglion of Walter, which is the lowest node in the paravertebral sympathetic chain. It represents the fusion of the two sacral sympathetic chains and is a single retroperitoneal structure usually found in the midline in the anterior aspect of the sacrococcygeal joint. It innervates perineum, the distal rectum, anal region, the distal urethra, vulva, scrotum, and the distal third of vagina. The main indication is sustained visceral and or sympathetic pain within the perineal region that is resistant to the conventional treatment. Injecting a combination of local anesthetic and steroid for ganglion impar block provides immediate relief due to the blockade of the nociceptive and sympathetic fibers. However, this duration of pain relief is short-lived and it may be repeated if the pain recurs. In recent years, a new method such as radiofrequency lesion of the ganglion impar has been started, which is basically a percutaneous, minimally invasive, safe and effective procedure for management of patients with chronic intractable pain. In conventional radiofrequency treatment, a 420 kilohertz high-frequency alternating current of 90 to 125 milliamperes is applied for a duration of 60 to 90 seconds. The RF electrode basically heats up the targeted localized tissue within the surrounding few millimeters by generating a temperature of 60 to 80 degrees Celsius, which in turn causes selective thermocoagulation of the pain-carrying nerve fibers, which is the A delta and C fibers. The aim of my study was to compare the radiofrequency thermocoagulation of ganglion impar with the block using a combination of local anesthetic and steroid in chronic perineal pain. The primary objective was to assess the pain relief using numerical rating scale following the radiofrequency thermocoagulation or a block given using local anesthetic and steroid. The secondary objective was to assess the patient's self-reported belief about the efficacy of the treatment using patient global impression of change scale. Also, we studied the side effects and complications, if any, occurred. After receiving Institutional Ethics Committee approval, this prospective randomized interventional study was conducted in the Department of Anesthesiology and Critical Care at Pandit B.D. Sharma Hospital, PGIMS Rohtak, who attended the pain clinic there. Informed written consent was taken, and 40 patients of either sex in the age group of 20 to 70 years who were suffering from chronic perineal pain, which was benign in nature and failed to respond to 6 weeks of conservative treatment was selected. The inclusion criteria consisted of known contraindications for nerve block in the sacrococcygeal area, active perineal infection, acute perineal trauma, history of perineal malignancies, history of adverse reactions to local anesthetics or steroids, previous history of ganglion impar blocks, previous surgery in the perineal region, uncontrolled diabetes mellitus, anticoagulants intake, and pregnancy. The sample size was taken to be 20 patients per group to detect the statistical significance, and it was based on the fact that difference of 1 in pain score in numeric rating scale. So pre-procedure assessment included the duration of pain the patient had, duration of pain for which the patient was suffering, pain distribution, region, aggravating factors, the pain score using NRS scale, and any intervention in imaging modalities such as X-ray, ultrasound, or MRI scan. Monitoring was done of the pulse rate, the blood pressure, ECG, and SpO2. Outcome was assessed based on the pain score using numerical rating scale 30 minutes before the block, 30 minutes after, 2 weeks and 1 month, and 3 months after the block. And patient global impression of change was assessed on a 7-point scale at 2 weeks, 1 month, and 3 months. The scale being very much improved, minimally improved, no change in the pain, minimally worse, much worse, or very much worse. The number of ganglion impaired blocks that the patient received was noted down with the date and the approach used, and the side effects such as bleeding, rash, rectal puncture, weight gain, itching, infection, paresthesia, neuritis, allodynia, deafferentation, pain was noted. So the results observed were the majority of the patients in this study were in the age group of 40 to 50 years, and 80% of them were females. Most of the patients belonged to the weight group of 60 to 70 kg, and majority of them had a history of trauma which led to coccydodynia. Both the techniques of injection, that is the fluoroscopy guided ganglion impaired block using corticosteroids and local anesthetic, and the fluoroscopy guided ganglion impaired radiofrequency thermocoagulation were effective and provided good pain relief for the symptomatic patients. The statistically and clinical significant improvement was seen in both after ganglion impair in both the groups at all time intervals except in the 30 minutes after ganglion impair block, which was better in the first group. Improvement in pain score was statistically and clinically better in group 2 as compared to group 1 at all time intervals in the rest of the study period. Patients' self-reported belief about the efficacy as per PGIC scale was clinically and statistically better in group 2 as compared to 1 at all time intervals throughout the study period, except at 2 weeks interval where the PGIC was comparable. 4 patients in group 2 required a second ganglion impaired block. No patient required a third ganglion impaired block in either of the groups, and the time interval between the 2 consecutive ganglion impaired blocks was 1 month to 2.5 months. Majority of the patients did not complain of any side effect. If any, was basically pain on injection, for which no intervention was required. We used image guidance fluoroscopy to perform the ganglion impaired blocks to ensure that the injected is providing good coverage to the target site via administration of contrast and to minimize the patient risk involved. To conclude, both the techniques of injection, that is the fluoroscopic guided ganglion impaired block using corticosteroids and local anesthetic and radiofrequency thermocoagulation are effective and provide good relief to the patient, symptomatic patients. With respect to improvement in the pain relief, the patient's self-reported belief about the efficacy of treatment, the side effects or complications, the fluoroscopy guided ganglion impaired radiofrequency thermocoagulation was better as compared to a block using corticosteroids and local anesthetic. These are my references. Thank you.
Thank you, Dr. Vishali. I open to the House for discussion. Over to you, judges.
So, Dr. Vishali, you've compared the RF with thermocoagulation and steroids, right? Ultimately.
Yes, ma'am. Yes, ma'am.
And both were effective, but the group 2, the thermocoagulation, was more effective.
More effective, yes, ma'am. Except in the immediate post-op period, 30 minutes immediately after.
That one.
In the rest of the group, yes, ma'am.
So overall, you would rate the second group to be more effective, is it?
Yes, ma'am. Based on our observations, yes, ma'am.
And you took the sample size as with a change of NRS as 1, pain score difference as
Pain
1.
score difference. Yes, ma'am.
So would that be shown as a SD plus minus something, or just pain score 1?
Ma'am, it was basically taken as a pain score difference of 1, but the standard deviation was plus minus was taken, but in only the clinical aspect of it. But we observed that it didn't.
No, I don't know how the calculation was made with the input of a pain score of 1. How do
Ma'am, we
we?
took a confidence level of 95%, ma'am, and.
Okay, this is based on some study, previous study,
Yes,
your
ma'am.
own
Yes,
pilot?
ma'am. No, ma'am. This is based on 3 studies that were carried out previously. One was by Lee et al., Leclerc et al., and Demicray, in which they all observed the pain scores. In one, it was taken as VAS. The other took PGIC, the self-reported belief of the patients. And the other one was basically a meta-analysis study using all the 3 methods and the different approaches, which is the transcoccygeal and sacrococcygeal approach.
Okay, and what are the limitations of your study?
Ma'am, the major limitation being that this study, in our study, the practitioner was just one. So it could be that it may not be generalizable to the rest of the population. Apart from that, ma'am, we only started it for a period of 3 months. So ideally, if we could have started it for a longer duration, like for a year or so, we would have gotten a better scope of how effective they both were. Apart from that, ma'am, double blinding was not done for the patients. So because it was not possible with the radio frequency thermocoagulation equipment being there and not being there. So it was not possible that way. And ma'am, also it is subjective. The NRS score and the patient global impression change score, they are subjective to the patient's reporting. So that could also alter a little of our results, ma'am.
Okay, thank you. Well presented, Vishali.
Thank you.
Good presentation, Dr. Vishali. Good study. So why do you think the second group had a better outcome?
Ma'am, if we see regarding the patient pain relief, so immediate, if we see, it's actually better with the corticosteroids and the local anesthetic because their onset of action is faster with them. But whereas if we compare it to the duration of how the prolongation for how much the pain relief the patient gets, sorry. So in that comparison, we saw that radiofrequency thermocoagulation actually acts on the nerve fibers. It causes the thermocoagulation of the nerve fibers. So the prolonged pain relief is way better with that.
Except the first 30 minutes you told. Why is it so?
Ma'am, because the onset of action is better. The onset of action with local anesthetics and steroids is better. It's more rapid.
Okay. Who was the observer who took the scoring, the pain relief scores? Was it different from the person who did the procedure? Was it a single person?
Yes, ma'am.
Blinded to which procedure was done on the patient? Was the observer blinded to which procedure was done on the patient?
No, ma'am. Actually, the procedure was carried out by my guide for both the set of groups, but the follow-up was done by both of us. So for the pain score as well as the PGIC, the follow-up was done by me and as well as sir.
Some amount of observer bias should be there probably, right?
Yeah.
So, okay. Regarding the long-term follow-up, you are telling we couldn't do limitation. Probably you would have a list of all your chronic pain cases. You still have your contact numbers of them. You can probably that rather than claiming it to be a limitation. You can always long-term follow-up is being done.
It's good.
It's good.
Yes, ma'am. We actually
because you always have a chronic pain book register with you with their contact numbers. So,
ma'am, I'm actually doing that simultaneously. I
don't
have done
state
it
it as your limitation. You are in the process of doing it already. You can do it.
Yes, ma'am. Sure.
Thank you.
Thank you.
Vishali, very well presented.
Good evening. Yes. Thanks.
So I have a small query. So you said in the group of thermocoagulation, no local anesthetic was given.
Yes, sir. Sir, the initial for the subcutaneous skin and subcutaneous tissue local anesthetic was given, but not for the procedure.
Not for the procedure. But
No,
the
sir.
challenge is that any coagulation, thermocoagulation or radiofrequency you may do, they are very painful procedures.
Yes, sir.
So
Yes,
it's
sir.
always a good idea to give local anesthetic just before doing a thermocoagulation or RF and immediately after it, because actually it is very painful because you are
It's
burning the nerves. So how do you justify not giving local anesthetic in patients of the RF group?
Sir, actually, in the side effects that we did observe, we did see a few patients complaining of pain there in the localized targeted tissue region. But sir, since the duration of the thermocoagulation was 90 seconds and the area was very limited, they didn't report a significant pain. Although the pain was there, and it could also of course affect our 30 minutes later pain scores as well. It could be that because of the thermocoagulation they say that the pain is still there, so that could also create a bias. But it was not it was not a moderate to severe level of pain. So if that would have occurred, we would have administered a local anesthetic, of course, for the patients.
So as a standard of care, you don't use local anesthetic when you're giving RF thermocoagulation in your patient. We don't talk about this study otherwise.
Sir, we do if it's trigeminal neuralgia, if we are doing radiofrequency ablation for that, around 1 ml or 2 ml of local anesthetic is given if the patient is complaining of pain during the procedure, but not on a very routine basis, until unless depending on the patient's response to the procedure, because everybody's pain threshold sometimes is playing factor in it. So depending on that, we would dose response thing is there, sir.
Okay.
Not on a routine basis for everyone.
Another question. So you, these patients, I believe, would be on some drugs in the pre-procedure period. So some analgesics, maybe opioid, non-opioid. So then you end up
Yes,
giving a
sir.
block. So what was the effect of the intervention you did on the analgesic requirement of the patient in the post-op?
Sir, post procedure, we during the follow up, immediately after follow up for a period of 1 month, they were routinely taking the same amount of medications that they were taking pre procedure. But as we compared for group one, the that reduced after a period of 2 months, 3 months, the requirement for drug dosages, but it most of the patients required an re-up of the drug dosages after like a period of 4 months or 5 months. So hence a lot of patients required a repeat injection. But as compared to that, in group two, the drug dosages reduced after a period of 1.5 months to 2 months, and thereafter it kept on decreasing, and analgesics were eventually for a few patients were not required after a period of time, sir. So they reported almost no pain in case of coccidodynia. A few of them did have lower back pain, so for that they did continue their medications, but not for coccidodynia. Specifically for that, they did not require any analgesic, opioid or non-opioid.
Okay. Thank you.
Thank you.
Thank you, Vishali. Thank you, judges. Dr. Charan, are you ready with your slides?
Anji, ma'am.
Okay. Over to you, Dr. Charan.
Is my screen visible now, ma'am?
Yes.
Good evening. I am Dr. Charan and I'll be presenting on the topic of comparative evaluation of efficacy of platelet-rich plasma injection with a combination of local anesthetic and steroid in chronic shoulder pain, done at Pain Management Center, Pandit B.D. Sharma, PGMS, under the guidance of Dr. Naveen Malhotra, sir, my guide. Introduction. Shoulder pain is characterized by insidious onset, progressive pain, and loss of active and passive mobility in the glenohumeral joint. Shoulder pain is responsible for approximately 16% of all the musculoskeletal disorders, with an yearly incidence of about 15 new episodes per 1,000 patients. It's commonly seen in the age group of 40 to 70 years. Frozen shoulder, also termed as periarthritis shoulder or adhesive capsulitis of the shoulder, is one of the most common causes of shoulder pain and stiffness in day-to-day practice. There is limitation in daily activities and impaired sleep quality due to night pain and fatigue, all of which result in the significant impairment in the quality of life. Chronic shoulder pain can be due to inflammatory, traumatic, or degenerative etiology. The source of pain may be muscles, tendons, ligaments, or joints constituting the shoulder girdle. In addition, along with the rotator cuff injuries, tendinitis, capsulitis, and tumors. The treatment is primarily aimed at the symptomatic relief, improving the joint mobility and function, and optimizing the quality of life. It includes both non-pharmacological as well as pharmacological interventions. The pharmacological treatment includes administration of acetaminophen, NSAIDs, oral or topical, and opioids, which can be oral or patches. The various interventional modalities available are intraventricular injection of local anesthetics, steroids, saline, platelet-rich plasma, suprascapular nerve block, erector spinal plane block, arthroscopic surgery, and etc. The intra-articular corticosteroid therapy is an established procedure for shoulder pain. The mechanism of therapeutic effect is related to its potent anti-inflammatory effect, whereas the PRP is an autologous concentration of human platelets in a small volume of plasma where the plasma concentration is high. Platelet concentration is higher than the regular blood concentration. The emerging evidence suggests that in addition to the role platelets play in hemostasis, PRP has a potential to have a regenerative effect on body tissues. So we decided to conduct this study to compare the efficacy of intra-articular injection of platelet-rich plasma with bupivacaine and steroid combination in chronic shoulder pain in relation to NRS score as our primary objective, and in assessment of improvement in the functional improvement using SPADI score, that is shoulder pain and disability index score, and to assess if any side effects as our secondary objectives. The present study was performed after institutional ethical committee approval, after taking written informed consent as a prospective randomized interventional study. A sample size of 20 per group was calculated with the power of 80%, confidence interval of 95%, and type 1 error rate of 5% to show a difference of 9.6 units in the SPADI score and 2 units change in the NRS score. Age more than 20 years, attending pain clinic patients were included in the study criteria who had history, physical examination, and pain pattern consistent with shoulder pathology, the X-ray shoulder joint findings corresponding with the patient clinical symptoms, and failure to respond to the 6 weeks of conservative treatment. These were my exclusion criteria: patient with uncontrolled diabetes mellitus, those who had history of immunodeficiency or collagen vascular disorders, infection or active wound in the shoulder region, recent history of severe trauma to the shoulder or the surgery of the shoulder, history of NSAID used for 2 days before the injection, if systemic use of steroid 2 weeks before the injection, or history of intra-articular steroid injection in the past 3 months, ongoing pregnancy or breastfeeding, or any adverse drug reaction to local anesthetic or steroids were excluded from the study. Using computer-generated randomization number table, the patients were divided into 2 groups. Group 1 patients were administered 4 ml of drug solution comprising 3 ml 0.5% bupivacaine plus 1 ml of triamcinolone, that is 40 mg. And group 2 patients were administered 4 ml of PRP, which was prepared by collecting 10 ml of patient's blood and centrifuging it for 15 minutes at 1600 RPM. And the upper layers of the buffy coat and plasma were separately centrifuged for 7 minutes at 2800 RPM, thus giving about 4 ml of PRP. During the course of the present study, no escalation in the dose of pharmacological agents was done. The patient continued to receive the pre-procedural medication and physical therapy, and if clinically permissible, the dosage of medications was reduced. However, no new analgesic agents or additional peripheral injections or central injections were administered during the study period. After the procedure, a sterile bandage was applied. No more than 3 injections were performed during the 3-month study period. Patient outcome was assessed on the following parameters after 30 minutes, 2 weeks, 1 month, 2 months, and 3 months after the procedure. The pain score based on numeric critic score, patient satisfaction, and SPADI score were calculated. The difference between the 2 groups was statistically not significant for age, gender, and height. The range of motion and radiological features were comparable between both the groups. However, when comparison of pain score was done using numeric rating score, in group 1, 30 minutes after the procedure and 2 weeks after the procedure showed statistical significance as compared to group 2, but the pain scores were comparable to both the groups at 1 month of study time period. But at 2 months and 3 months study period, group 2 patients had significantly lower pain scores as compared to group 1. And a comparison of patient satisfaction score in both the groups showed that at 30 minutes after the procedure and 2 weeks after the procedure, patients in group 1 were better satisfied with the scores of 61 and 66, and both p-values less than 0.001. and patient score were comparable between at 1 month after procedure, and after 2 months and 3 months after the procedure, patients in group 2 were better. Patients had better satisfaction score in group 2 with p-value of less than 0.001. Comparison of SPADI score between both the groups. The SPADI scores in 30 minutes after the procedure and 2 weeks after the procedure were significantly better in group 1, and it was comparable in both the groups at 1 month after the procedure, and SPADI score was comparably lower in group 2 and 3 months after the procedure in group 2 who had received PRP injection. At the end of the study period, better patient satisfaction were observed in group 2. One patient in group 1 required second injection during the 3-month study period. Rest all patients required only one injection during the study period. Pain on administration of the injected was observed in most of the patients. Majority of them has moderate pain on administration of the inject. However, the pain was temporary and was relieved within few minutes of administration of the injected. No procedure complications were seen in both the groups. So to conclude, intra-articular shoulder injection of PRP for treatment of chronic shoulder pain is comparable to the intra-articular injection of bupivacaine and corticosteroid. However, intra-articular shoulder injection of PRP provides sustained pain relief and improvement in functional disability as compared to the intra-articular injection of corticosteroid with bupivacaine. Thank you. These are my references.
Very nice, Dr. Charan. Very well presented also.
Thank you, ma'am.
I just one thing I didn't understand was 1 month after the procedure, there was in your observation, in both there was a very different kind of result.
Both the groups had comparable scores in 1 month of the study period, ma'am.
And how was that? Because rest of the time there was very significant difference. And
so it shows that maybe the effect of action of the steroids is short living, so it might live up to the 1 month as compared to 2 months, ma'am. And the effect of PRP takes about 1 to. It is showing that it might take the better effective at 1 month period after the injection, ma'am. So around 1 month of time, the patients had comparable who had received both either the steroid or the PRP.
But later, after 1 month, also you had another reading, no? That was after
yes,
2 months.
After 2 months and 3 months, patients who had received steroid had developed pain, ma'am, as well as their SPADI scores started going significantly higher as compared to the group 2, ma'am.
So before 1 month and after 1 month, PRP was found to be better. But at 1 month, they were same.
At 1 month, yes, ma'am. Both the PRP and steroid were comparable at 1 month in terms of patient satisfaction as well as pain score and SPADI score.
Okay. I still haven't understood, but I guess there is more to it. Yeah. Okay, that's all from my side.
Good study, Charan. But once again, I also had a confusion regarding the same thing. Why was the difference not there at one time point? Probably you can just relook at it. Why is it so? Probably somewhere in the literature you would find.
Okay.
Was the patient on some kind of analgesic medication prior?
Yes, ma'am. Before coming to the ma'am, we are in choosing our pre-op patients only. We have taken those patients who did not respond to 6 weeks of conservative treatment as the inclusion criteria.
Have any of your 2 groups of patients needed any other analgesics?
Ma'am, we did not add any procedure, like we did not add on any treatment because it might skew the results. But yes, ma'am, we had modified.
Having pain, still you haven't given, or you didn't have any patient who didn't have.
But most of the patients didn't have any pain, ma'am. Those who had, in the group 1 patient, we gave another steroid injection, ma'am.
Okay.
Among the 20 patients, we had given 1 more steroid injection, repeat second injection.
And who was giving this PRP injection? Both were done by a single person.
The injections were done by the single person, and the observation, variations, and the follow-up was done by me.
So the chronic shoulder pain was subsequent to some kind of injury or something. What was
no, ma'am. We didn't include the trauma patients in our thing, ma'am.
It's
most
recent
of the
trauma, so I was.
No, ma'am. We didn't include because we more focused on osteoarthritis or frozen shoulder as the
Okay. All trauma cases you have excluded, not
हाँ
only
जी
recent trauma.
No, yes ma'am.
Okay. So, so again, the main question that Dr. Rakhi started in the initial thing. So, it is unlikely, some drug is effective initially, so it has to be good at least for some duration, and then the other, we can believe that the other drug has slower onset and eventually it is a long.
Sir, that might be what I'm trying to suggest, sir, because the PRP is taking longer time to onset, like the onset is also longer and the duration of the pain which results is also longer. So we have not studied after 3 months of period. Maybe if we had studied after that, we might have seen that
Yeah, but
effect.
if the onset is longer, then they should the analgesia at 1 month or less should be inferior.
Yes, sir. In the group 2, it is inferior, sir. Group 1, at the patients who had received steroids had better pain relief at 2 weeks of time as compared to.
So since the patient in PRP did not have good relief at 2 weeks, what did you do that time?
Sir, the patients who are having that, we had given them the pre-procedure, whatever the analgesics they were taking, we had continued them.
That was continued.
Yes, sir. Like in both the groups, we had asked them to continue, and after 2 weeks, if they had come and if they had shown that the pain score was less, we had reduced the dosage, sir. That which we had reduced for most of the patients in group 1, but in most of the patients in group 2, we had not reduced the dosage, sir, because they had pain still.
So percentage-wise, what was the event that you could reduce the dosage of the pre-procedure analgesic in group 1 versus group 2?
Sir, that we had not included that in our study, sir. So I had
Well,
not
that is an important finding which
yes, sir. Now, before giving this paper for publication, we'll include that as well.
Because patients are worried, they are on 5-6 drugs, they don't want to take the drugs, and if you are able to show that the
reduction in
reduction
the yes,
that is the job.
Yes, sir. Yes, sir. So that's what we had not done that. We had not included that in our study period in this protocol of the study, sir. So before publishing, we'll add that into our study.
Okay. And secondly, what is the cost benefit of PRP versus steroid? So what is the cost of PRP with respect to steroid?
Sir, for us, the tricot should be bought outside, sir. Rest everything is available inside. The tricot costs about $150, sir.
No,
150 rupees.
Okay, but somebody is buying even in the hospital. No, what is the cost of PRP with respect to a steroid intervention?
Sir, PRP is definitely higher, sir. Like PRP is about roughly about 7 to 8 times higher than this.
Okay.
We have a PRP machine in the institute itself, so patients just need to get the vial for that getting PRP done, sir.
Okay. Fair enough. Okay.
Thank you, sir.
Thank you, Dr. Charan. Thank you, judges, so much.
Thank you.
So that concludes our session for today. We've had all our speakers today.
Thank you very much, Dr. Neha. Thanks to all the esteemed judges for giving your inputs and concluding the session so well. My heartfelt thanks to the judges, Dr. Rakhi Goyal ma'am, Dr. Vijayalakshmi ma'am, Dr. Nishkarsh, and very heartfelt thanks to our patron, Dr. Tejki Kaur sir, for being always there as the guiding torch. To all the candidates, it was a wonderful presentation from your side, and the results of this session would be declared on 2nd of Feb at the end of the session. You'll get the certificates through your mails, and the 3 prizes are there for this session. First prize carries the cash award of 10,000 rupees, and second prize carries the cash award of 5,000, and third prize carries the cash award of 3,000 rupees. Once the candidates who will be winning these awards, they will be informed, and the money will be transferred. The award will be transferred to their bank accounts. Thank you very much. It was a wonderful evening. See you all tomorrow at the same time, 6 p.m. for another session.
Dr. Vishal,
Yes, sir. Yes, sir.
We must appreciate the presence and the efforts taken by all the 3 judges. Hats off to them for staying continuously and listening for 4 hours continuously. It's a great job.
Right, sir.
They need
exactly,
a special appreciation and a special award from the society. They have really done a commendable job.
Sure, sir.
God
Sure,
bless
sir.
them, all the three,
Sure.
and of course, under your and the President, Dr. Indrani's guidance. God bless you. Thank you. Thank you all.
Thank you,
Thank
sir.
you all.
Thank you so
Thank
much.
you.
sir.
In fact, it's a real honor, sir, and more so in your presence. You were there throughout, and we
You
could
have
get
really
your
done a
excellent
great job. You have
comments and
really done a great
experience
job.
shared.
Really done a great job. God bless you.
Thank you
God
so
bless
much, sir.
all of
Thank
you.
you.
Thank you. Thank you,
Good night,
Vishal.
everyone. Good night, everyone.
Thank you.
Thank you, sir.
Excellent job.
Thank you, sir.
Thank you, Dr. Vishal.
Dr.
Thank you very
Vishal.
much.
Long live Rsacp.
Good night.
Thank you.
Long live us.
Good night.
Please